And we can start.
Okay, hello to everybody. Good morning on, I suppose, all coasts, and welcome to ADAA's 2021 Fall Forum. It's a virtual Fall Forum. This year's topic is depression across the lifespan. My name is Barbara Kamholz. I'm a clinical psychologist and associate professor of psychiatry at BU School of Medicine and senior advisor of professional education for ADAA, and I'm going to be moderating our event today. Before we get started, I'd like to go over a few items so that you know. Let me see if I can get my slide to go forward. All right, technical snafu number one.
If you want to unshare and then reshare, you might be able to get that to move forward.
I'm going to try one more time. My apologies to everyone out there. You'd think 18 months into COVID, I could have had this a little bit more smoothly. Let's see what happens. I'm going to leave it like this. I'm aware it's not in the slideshow mode. I'm just going to leave it like this to see how we go. So before we get restarted, I want to go over just a few items so you know how to participate in today's webinar. As a note, we are recording today's webinar. That's both for us, for you, and for anyone who's not able to join us today. The webinar will be available on demand within 24 hours. And for those of you who applied for CEs or CMEs, you're going to receive an email within 24 hours of this webinar with the link and instructions for getting those CEs. So I'm delighted and honored to introduce our individual speakers and panelists today. We have two really incredible keynote speakers, Dr. Alan Schatzberg and Dr. Gabriela Liva-Stein, as well as a panel that's going to be led by our Fall Forum chair, Dr. Gabrielle Liverant, and will also include Drs. Namki Choi, Sean Jones, and David Michulan. So before I turn it over to Dr. Schatzberg, I do want to just introduce him for those of you who may not know him, and I'm guessing there aren't very many of you. Dr. Schatzberg is a Kenneth T. Norris Jr. Professor of Psychiatry and Behavioral Sciences at Stanford University School of Medicine, where he is the director of the Stanford Mood Disorder Center. He is the former chair at the Psychiatry and Behavioral Sciences Department at Stanford. He is a former president of the American College of Neuropsychopharmacology, former president of the Society of Biological Psychiatry, and the former president of the American Psychiatric Association. I cannot possibly do justice to his over 350 publications or to his awards, but just to mention a very few, he is the recipient of the Gerald Clareman Lifetime Research Award from the National Depressive and Manic Depressive Association, the Mood Disorders Research Award at American College of Psychiatrists, the Lifetime Achievement Award of International Society for Psychoneuroimmunology, the Judd Marmer Award for Biopsychosocial Research at the American Psychiatric Association, and the Donald Klein Lifetime Achievement Award at the American Society of Clinical Psychopharmacology. So I think technically he has contributed 3 lifetimes to our field, and we are tremendously honored and grateful to have him here today. And with that, I will turn it over to you, Dr. Schatzberg.
Barbara, thank you very, very much for the very kind introduction. And I'm delighted to be with you folks today and delighted to participate in the ADAA Fall Forum. The ADAA has done yeoman work in providing education, providing resources for patients and their families, providing a major annual meeting that is incredibly well attended and has a diversity of approaches and supporting the efforts to know more about depression and anxiety disorders. So I'm just delighted to be here and to talk today about, let me see if I can get my slides up. That's the next thing. Okay, I think there should be, okay. And talk about the pros and cons of where we are with new antidepressant development. And this is something I've gotten very interested in, not only from the question of efficacy, but from the broader issues as to where we are with drug development and where we're headed, and what are the kinds of assumptions that we're making in drug development that may be erroneous, and that we need to be, I think, more mindful of where the field is going. Now, let me see, I can advance it here. This is a disclosure over the last 3 years. I've worked with lots of companies. I am going to say something about a few companies in particular, I think, that are germane. Janssen, who makes Spravato, Sage, who makes brexanolone and zuranolone, and Compass, that's involved with the development of psilocybin. So I will say some things about that, and I have worked with those companies on and off over the last few years. So the learning objectives is to kind of review recent data on current drug development from a mechanism of action perspective in a broad sense, and discuss how mechanisms of action can affect the risk-benefit ratio. And they're important to establish because the risk-benefit ratio may vary depending on what the mechanisms of action are. And to go over some of the information that we do have about efficacy and side effect data of new antidepressants, and particularly those that are under development. So most of what we have today, and what we use today in the treatment of depression, involve enhancing norepinephrine and serotonin monoaminergic synaptic activity. The drugs like the SSRIs, Prozac, Paxil, Zoloft, the drugs like the SNRIs, venlafaxine, duloxetine, work on this area, as does pretty much Trintellix. And they're tried and true. They provide reasonable efficacy and reasonable safety, but there are patients who don't respond. And the fact that there are patients that don't respond has led us to try to develop more and more treatments that could work with alternative mechanisms of action. We have a certain category of patients that don't respond, that are refractory, and those patients then present challenges for us in terms of how best to help them. But one of the bottom lines is, as we look for ways to improve outcome, we tend to kind of have shifted, and I think somewhat unconsciously, towards the development of drugs that have greater risk in terms of dependence, potentially, in terms of mind alteration, et cetera. And that shift has changed the risk-benefit ratio. It hasn't eliminated the development of these drugs, but I do think it is important for practitioners and patients to be aware that there are some risks and that we need, in fact, to develop more data. So we're going to talk a little bit today about the serotonin 2A agonist. We're going to talk about glutamatergic transmission. We're going to talk about GABAergic neurosteroids primarily. And we will talk about MDMA, which is an amphetamine-like compound that is used in the treatment of PTSD. Now, before we get into the drugs, there are a few things that need also to be said besides the question of the risk-benefit. And that is that some of these drugs are not used just in a pure pharmacologic intervention. And we have long kind of done studies on combining drugs with psychotherapy. You see this in studies in alcohol use, in studies of alcohol with comorbid depression, where there's a drug, and or in chronic depression, where we did a lot of studies with Marty Keller, who was the previous chair at Brown on chronic depression. And some of the studies combined a certain type of interpersonal therapy with drug compared to drug alone, or and to see if you got an enhanced effect. So we are used to that. What we're not used to is kind of an alternative application of drugs, which is to use drugs to enhance a psychotherapeutic action. And that's a very different, it's nuanced, but it's very different. And so you see in California particularly, therapists who have long used ketamine to guide their psychotherapy, or they use some sort of other hallucinatory compound, PCP, or psilocybin, or LSD, that in fact is used not just as a drug, but as a drug to enhance the therapy. So keep that in mind, because some of the studies are done in that way and may have a different kind of pharmacology than we're used to thinking about. Now, this is just to remind you about the serotonin system. Typical view of the synapses comes from a textbook Charlie Nemiroff and I have edited for 5 editions. And the slide came from Husseini Manji when he was at the NIMH. There's a presynaptic neuron which contains serotonin. This serotonin is released, interacts with postsynaptic receptors, and most of the serotonin is taken back in a process called reuptake into the presynaptic neuron. SSRIs work by blocking that transporter. They cause accumulation of serotonin in the synapse, which allows then for stimulation of postsynaptic receptors largely. And there are a number of them. But over here, you also see that there are, and one of the receptors is serotonin, set of receptors, or serotonin 2 receptors, 2A and 2C. And these drugs do interact with serotonin, but you can supercharge these drugs, these receptors. And if you give a very potent agonist, LSD, for example, or PCP, you can in fact drive the postsynaptic system in serotonin. So we always have a kind of an issue when we're going to talk about some of these hallucinatory drugs that are driven by stimulating serotonin 2 receptors, as to whether in fact, is this a kind of an antidepressant effect that's based on a super agonistic effect at the serotonin 2A, or is it in fact a mind-altering experience that then is combined with some sort of supportive or insightful kind of therapy? And those are very different kinds of effects. And so we really need to really understand that better, because obviously repeated mind alterations can be problematic in some patients. And we all remember, at least those of us who are old enough to remember, the untoward effects of LSD use in young individuals who are probably at risk for developing a psychotic disorder such as schizophrenia, and seeing these untoward kinds of reactions. So here's psilocybin. Psilocybin is related, obviously, to serotonin. It is an agonist for the postsynaptic receptor, 2A receptor. And you can see here it has a phosphate kind of, O-phosphate kind of radical that's attached, and lacks a hydroxy on the benzene ring. And psilocybin is a 5-HT2A agonist. It comes from certain mushrooms that are psychedelic. It has a low abuse liability in animal models. Animals don't like to be psychotic. Some patients, some subjects like to be psychotic, and it's used, in indigenous populations as a kind of a quasi-religious mind expansive experience. And it was studied as an adjunct to psychotherapy in the 50s and 60s. And the research was largely halted when in the 70s we had the Nixon administration really try to do a war on drugs and included the hallucinogens under that rubric because of uh, kids who were hippies and using drugs were kind of, well, I think, largely offensive to the right wing government that was in power then. Now, psilocybin, though, has been used in conjunction with some sorts of supportive or guided therapy. And originally, the first blinded studies were in patients who had comorbid depression and anxiety who had terminal cancer. Got a diagnosis, got depressed, got anxious, but most of these people did not meet criteria for major depression. And there were two studies, one done by Roland Griffiths and colleagues at Johns Hopkins and one done by Steve Ross at NYU, to look at the comparison of psilocybin against placebo. And the placebo was either a low dose psilocybin or niacin. When you give niacin high enough doses, you get a flushing and a kind of a peculiar kind of feeling. You don't necessarily become psychotic, but it does have some vasomotor kinds of effects that people think could be used as a control. But herein already, we have one of the problems with the development of drugs that are dissociating or cause hallucinations or some mind alteration. They're extremely difficult to blind the studies because you got a full dose, you got a full dose. And there is been a peculiar thing in investigators to not inquire about the blind, either the principal investigator or the patient. And because it could affect what people think about the next patient or whatever. But to me, that's very hedgy and dodgy. The reality is these are extremely difficult studies to blind. And so we are always stuck with, is this really a drug effect that is being reported, or is it just that the blind has been violated? Now, there are ways of getting around this, and I'll come to one in a second. One time is, when the most studies now look like they're going to be set on giving a single or two doses spread apart of psilocybin at 25 milligrams. They have done some studies, they're ongoing also against 25 against 10, but a low dose of 1 milligram has been proposed to give a little something for as a kind of a micro dosing for the patient. Whether that really will be sufficient is really unclear. And so you get these kinds of studies, 30 megs for a 70 kilo person based on a 0.3 meg per kilo basis. But 25 is kind of the dose. And in these studies, both studies were positive with those caveats that, in fact, patients who got the active drug felt less anxious. They felt less depressed. They were more in sync with their lives in terms of what it meant to be potentially terminal, and more comfortable with it. So it had a positive benefit. Whether that translates into a true antidepressant effect, unclear. And Robbie Cathett-Harris, who's in the UK, who was a postdoc working with David Nutt, a very well established pharmacologist, reported an open label psilocybin study in refractory major depression, where they gave 10 milligrams on day 1, 25 milligrams on day 8. So here you got a 10 and a 25. And 8 of the 12 responded, and 7 of them maintained the response. But many of these people had tried psilocybin, so they were not naive to the treatment. So that's one issue. This was open label. It wasn't even an attempt to blind it, let alone to have an active control. Then more recently, Cathett Harris Harris reported a paper in the New England Journal, got a lot of press. 59 patients, moderate to severe depression, double-blind random assignment, 6 weeks. They got escitalopram daily, all the patients, or they got with placebo, or they got escitalopram with 25 milligrams given twice, 3 weeks apart. The other group was escitalopram with the 1 milligram twice. So it wasn't quite a true placebo, but it was the control. And there was numerical superiority on the primary endpoint on the quids at 6 weeks for the 25 milligram group. That's good, over the 1 milligram group. And there was statistical significance on secondary measures. So it's not really a positive trial, it's a failed trial in that it didn't separate, but it did suggest that on the other measures, it seemed to work. There are a few criticisms on the study. One is that 30% in each group had in fact used psilocybin, so they knew what psilocybin feels like at a full dose. They didn't inquire about the blind as another issue. So it's hard to fully interpret it. It is suggestive of, in fact, having a positive benefit. And so we need larger studies, and we need better controlled studies. Now, one of those studies has in fact finished enrollment. It is a 22-center international study sponsored by Compass Therapeutics, and the comparisons are 1, 10, and 25 milligrams. And they use the standardized psychedelic psychotherapy. So this is very important. And we were one of the sites, Chuck DiBattista ran our site. So patients, in fact, get 3, 4, 5 meetings with 2 therapists prior to taking the psilocybin. During the psilocybin, the 2 therapists are present. They don't interact. They're available if the patient, in fact, wigs out or whatever. And then there are debriefing meetings over the next few weeks. And so they look at the outcome at 6 or 8 weeks, and there is some ongoing kind of supportive work. So it's obviously labor intensive is one. 2, there is support for both groups. In this case, 3 groups. There were 3 different doses. So it's not just you drop a pill and come back in every 2 weeks and we'll rate you. So there is a therapy background here. And it gets at this question of, is this really an interaction of a mind expansion with a therapy that could, in fact, provide benefit? These were people who had not taken psilocybin. These were not refractory patients. And so this is the first really large multi-center trial to see if, in fact, 25 milligrams is significantly better than the other 2 doses. And we will know, I would think, in the next 3 or 4 months. The enrollment is done, the patients are finishing up, and it is a well-designed study. I've been involved with the company in helping, discuss designs or whatever. So I think it's a real serious effort to try to understand how about treatment, developing a novel treatment. Now let's switch to glutamate. Glutamate is kind of the energy, the oxygen of the brain, if you will. This is an excitatory neurotransmitter and interacts with multiple different types of receptors. And the reason for that is that these receptors are conserved because you can't live without glutamate. And so if something happened to one, another would have to pick up to maintain central function. This, another slide from our textbook, shows you 3 of the major receptors: the AMPA receptor, the NMDA receptor, and the mGlu-R receptor. And this receptor here can be blocked, and ketamine blocks that, and that gives you anesthesia. It gives you a sedation for surgeries, things like that. And ketamine has been developed as a putative NMDA antagonist. And I say putative because it has other effects. First of all, clinically, it works in chronic pain. It works as anesthesia. It's used primarily intravenously historically. A lot of it in kids, relatively short acting in terms of the unconsciousness or sedation. And it's been said to be an NMDA antagonist. But it's also a weak mu opioid agonist, and it also appears to cause a release of dopamine and be a stimulant. It causes a release of opioids. It looks like to give you analgesic effects. It is psychotomimetic, and it can cause dissociation. And the studies in the development of an antidepressant are a little different than psilocybin in that it's been used as originally as a single infusion of ketamine at 0.5 megs per kilo, given over 40 minutes. And when you do that, you see nice separation in about 110 minutes from the placebo, and that continues out for a few days. And then by day 7, the two curves come together. This was a crossover study for the patients, and one time they got placebo, one time they got ketamine. And in this study, Wilkinson took the studies that had randomized patients to ketamine or a control, and sometimes it's midazolam, sometimes it's placebo. Midazolam is Versed, used in colonoscopies, again, another anesthetic agent, another used in anesthesia. And you can see here the patients report considerable decrease in their suicidal ideation with ketamine compared to controls. And it does seem to, in fact, separate better at day 7 than does the antidepressant effect. These studies historically are not done as a guided therapy. There are some efforts now to do that, but this has really been a pure drug effect. However, when the patients get the infusion, they are not alone. I mean, there is an anesthesiologist or another physician. There is a nurse. There is often a research assistant. So there's a lot of hand-holding, particularly for the 2 hours. Well, if it only lasts a week, what do you do? And this, James Murray, a nice paper a number of years ago, showed that if you had a test dose on the ketamine that the patients who responded when they were given ketamine again responded over the next 2 weeks. They were given this 3 times a week, and the non-responders continued to non-respond. And it similarly for the dissociation, there wasn't a tolerance to the dissociation. So you can start to give a repetitive ketamine, and Janssen has developed Spravato, which is an intranasal formulation of the more active enantiomer. So drugs have usually 2 enantiomers, an R and an S, that are mirror images, but they're not mirror images beyond structure, because one is usually more active, the other is less active, and one can have less side effects as well. And so S-ketamine is really the more hallucinatory dissociative, and they patented and developed an intranasal formulation. And in this, the first study you can see here, these were suicidal patients, and they were randomized to adding Spravato or adding placebo to one of 5 different accepted antidepressants. So it's antidepressants plus Spravato, antidepressants plus placebo. So there's a big background effect here. And in day 1, they got a nice separation, and they got a nice separation at day 2 as well of Spravato against placebo. But when you look here at the follow out, as you follow people out, the curves come together a lot faster. And that's probably because patients are getting their antidepressant. Some of these involved hospitalization because they were suicidal. But it also suggests that there may not be that much more benefit than continuing just the other antidepressant. So But there is this lack of, often in many of the Spravato studies and many of the ketamine studies, over time, there is kind of a coming together of the curves and a loss of statistical benefit. When they filed, there were 3 blinded studies and 1 geriatric study. Only one of the studies was positive. There were 2 that showed statistical trends, but not significance, with a mild effect size. And there was a maintenance discontinuation trial that the FDA allowed for proof of efficacy that was shown. Now, this is one study with antidepressant plus esketamine in the green, antidepressant plus placebo. And as you can see here, you get this nice separation, but you don't get enhanced separation. So if you look at most drug trials, you get separation and you get usually continued separation, continued gain. So this really kind of, it says you're not getting more gain as you use the drug over time, which is always kind of a question of how to interpret the efficacy. What was interesting about the discontinuation trial, so these patients got I believe they got twice a week Spravato plus drug, plus other drug, or twice a week placebo for 4 weeks, once a week for 4 weeks. And then they go into a taper where they're maintained on once a week, once every 2 weeks. And at the end, then they're randomized to continuing on placebo or the continuing on the active drug. And what you saw here, which was striking, is a relatively rapid relapse in patients who had been treated for a considerable amount of time at the point of stopping. So at day 50, since the randomization, you can see statistical significance with greater relapse on the people who went to placebo than the people who stayed on Spravato. And that difference continues throughout the whole study. Now, how to interpret that is unclear. The FDA in their briefing document pointed out that this was twice as strong a discontinuation effect as is seen of just coming off drugs like Paxil or Prozac, where you in fact go off the drug and 25% relapse, 50% will relapse over 6 months, but it's very slow, and 25% relapse staying on placebo, on active drug. But here you see this rapid relapse, even though patients are still on Spravato, are still on their other antidepressant. And what was particularly alarming in the development program is that there were a number of deaths, in treatment resistant. And 3 of the deaths were ending the open label treatment after the last dose of esketamine, at 12 and 20 days and 4 days, patients committed suicide. But the concern is here, the patients were never suicidal, because these patients in these studies were selected for a lack of suicide, but more for refractory. And the patients had seemed to be had responded. So you had people responding, then going off the drug and then killing themselves when they were not previously suicidal. The other 3 cases, deaths, one was a motorcycle accident that occurred 26 hours after the patient's last dose of esketamine, which is kind of worrisome too in terms of depressed patients using motorcycles and dying. Does suggest that there might be something going on. Now, the FDA in their briefing document said that the 3 coming off drug can't be related to the drug because they came off the drug. And that, to me, is a silly statement. If you were taking heroin or morphine and you killed yourself stopping a week or 2 later, you wouldn't just say it can't be related to the drug, right? I mean, these drugs, as I will show you, these drugs like esketamine do have an opioid component. So it is important to consider. in terms of stopping eventually. Can you get these people off Spravato over time? And maybe you can. And maybe it'll be sort of like a Suboxone, where it's very hard to get people off and they have to stay on it. Now, I say this because the other question with ketamine is there are a lot of other NMDA antagonists. Memantine is an NMDA antagonist, has been studied extensively in depression, has never been shown to have an antidepressant effect. This might be the last one where Eric Lentz and his colleagues at WashU looked at memantine versus placebo and in a low-risk comparison in nursing home and found that there was no difference between memantine and placebo. And there have been multiple studies. And the attempts to develop other NMDA drugs so far have failed. None of them have shown efficacy. I mean, so we can't just say it's NMDA antagonism is the answer, because we're going against against logic. Now, we started to argue that maybe it's actually is acting as an opioid, and the idea occurred to me when I saw Carolyn Rodriguez study, and she came to us from Columbia. At Columbia, she did a study where she looked at IV ketamine in heavily refractory OCD patients. And she found a dramatic effect, and it lasted 1 week. So one might say, well, that's another NMDA antagonist. But there was a paper that always intrigued me from a good friend and colleague who ran our OCD program at Stanford for many years, Larry Coran. And he did a double-blind crossover of lorazepam, morphine, single dose, or given twice over 2 weeks, or placebo. And he found oral morphine. The next day, the patients felt very, had a relief of their OCD, and it lasted for more than a week. And so we started to make the argument, well, maybe in fact, this isn't just chance, then maybe in fact, it is acting as an opioid. And then this paper came out from Pacheco in Brazil, and they looked at naloxone's ability, and that's like naltrexone, a mu opioid antagonist, to block the anti-pain effects of ketamine. And they showed that, in fact, you got a very nice blockade. You got a nice effect for ketamine, and as you increase the dose of the naloxone, you eventually got to a point where you totally blocked the ketamine anti-pain effect, the antinociception effect. And you did not see it with naltrexone and saline. They also reported that kappa may have a role here too. So in their study, they did suggest that ketamine might be working through a release of opioids, of endogenous opioids, and that maybe that's why naloxone was effective. So we started making an argument in the field that we could. This is potentially an important issue. Step back for a moment. We're giving an intravenously administered agent that is a street drug of abuse. So ketamine is abused on the streets, Special K in nursing homes. If you go to China, there are hundreds of thousands of people in South China who have are snorters of ketamine, and ketamine has been banned for use as outpatients in Australia, in Singapore, and other places, because people have in fact abused it if given the drug ad libitum. So we have a drug that is a drug of abuse. We know that it's intravenously administered. It works rapidly, and it's being at that point was being studied for intranasal use for snorting. Seemed to me that we ought to be quite conservative and understand how it's acting and rule out whether it is in fact acting as an opioid. And we did indicate that you could test it. You could test it out. You could use an antagonist like Pacheco did, naloxone or naltrexone, and you could block the antidepressant effect in animal models as well as in patients. Very simple. Very rare in psychopharmacology, I have to say, to say this is, you can test this hypothesis and actually go ahead and test it, which is what we did. Nolan Williams, who's assistant professor in our department, Boris Heifetz, who's in our department and is really primarily in anesthesia, led it. And what we did was we structured a study that was based partly on the Zerati original study for ketamine, in which we said we're going to give depressed patients who are refractory, we're going to give them 2 doses of ketamine, and we're going to give it to them when they're actively depressed. So we're not going to have carryover effects. We'll wait anywhere from 2 weeks to 6 months, and the longest we waited was 9 weeks. But we're going to give them the ketamine open label, so they know they're getting the ketamine. But what we're going to do is we're going to 40 minutes before, because we know the peak effect of peak brain concentration of naltrexone is at 40 minutes. We're going to give the patients 50 milligrams of naltrexone, and naltrexone is approved for drug abuse. It's approved for treatment of alcoholism or placebo. So it's a real placebo-controlled trial, randomly assigned, double-blind. The patients won't know, we won't know. And we will see what happens to the patients. And if you look at and we will cross over the patients from naltrexone to placebo, vice versa. And when you look at all the crossed over patients, you can see that the patients who got ketamine placebo do much significantly better than the patients who get ketamine and naltrexone. If you look at all infused patients, because 2 dropped out in the first time point, you can see that you get this nice, you get a response, and this includes people who didn't respond to ketamine plus placebo as well, and you see this nice significant difference. But where the most dramatic effect is in these dramatic ketamine plus placebo responders. So they're getting ketamine and naltrexone, but not naltrexone before. They get this huge ketamine effect. These, by definition, are ketamine responders. Because don't forget, you'll have ketamine non-responders, either on placebo or on naltrexone. And here are those same patients, the same controls when given naltrexone. And you can see here, they show no response. So these aha kind of responses that you see, we could totally block double blind by giving naltrexone. But we couldn't block the dissociation. This p-value here is crazily significant. We stopped the study halfway through because we had such a dramatic effect. And ketamine is not a very pleasant drug, and naltrexone ketamine is if anything a little less pleasant because you get a fair amount of nausea. Now, the ketamine naltrexone group, if you look at the suicidal effects, here you get the ones who showed the nice ketamine plus placebo response showed a very nice anti-suicidal effect. Get the naltrexone, no effect. And you can do this either with the Hamilton item or the Madras item. Antidepressant effect is blocked by naltrexone, and a suicide effect is blocked by naltrexone. Could it be the patients knew that they were getting naltrexone? Well, here are various, the ratings on the visual analog scale 5 minutes before the infusion, but 35 minutes after the patients have taken the placebo or the naltrexone. You can see here there's no real difference in drowsiness, alertness, or feeling high or restlessness or whatever. So it wasn't that they knew that they got the naltrexone. Naltrexone does not appear to exacerbate the depressive symptoms. I think for addicts, they lose their ability to feel high or whatever. And it doesn't seem to block antidepressants. For example, Contrave is a combination of naltrexone with I'm blocking bupropion. So now, having published that, there are now 5 reports replicating this and using animal models preclinically. And they've appeared in PNAS and molecular psychiatry. The two are posters that are in press, whatever. So, and we actually did an animal study before we published our clinical. And there are 2 more groups that have written me. So there are at least 7 groups that will have replications of mu opioid antagonists blocking the ketamine effects. Now, here is the most dramatic, and that was the Bonaventura paper. I want to point out three things. One, when you look at S-ketamine, it binds really to three receptors that they screen for: mu, kappa, two opioid receptors, and NMDA. So, and they bind at similar micromolar concentrations. So these drugs are not just NMDA antagonists. Where this idea of NMDA antagonist comes in is because the prototype of these drugs, MK801, which was developed 40, 50 years ago, is a massively potent NMDA antagonist. But S-ketamine, ketamine, not particularly. And you can see here for the opioid receptors, it binds as very similar to receptors, but not quite as potent as morphine, as you can see down here. Morphine is more potent, but it is a weak opioid agonist. And the animals will, in fact, self-administer. Here you can see here the S-ketamine. Once they get trained, they self-administer like crazy. They show place preference up here, which means they go to the part of the cage where they got the S-ketamine. And so it does, in fact, is habituating. And why this is important is that there are a number of other drugs that are under review or being developed that have a touch of an opioid effect. This may not be all bad. It's really a question of, can we control it? Dimethadone, which Relmada as the company claims it does not have abuse potential, but it similarly effects on NMDA antagonism and the mu opioid receptor, micromolar. There's buprenorphine, dextromethorphan, that's in front of the FDA now. Dextromethorphan, when metabolized to the demethyl metabolite, acts as an opioid. The use of bupropion is to divert that. And there are others. There's tianeptine derivatives. There are kappa antagonists that are thought to be not addicting, that could be safe opioid agents. So a lot of interest here. We need to keep the perspective open. Now, let me switch a little bit to GABA for a few minutes. This is the place, and this is the GABA, the A receptor, and this is where benzodiazepines bind. And GABA is the brake to glutamate. Glutamate's excitatory, GABA is inhibitory. And you can see here, there's a benzodiazepine site, but there are neuroactive steroid sites that these drugs, like allopregnanolone, will bind to these sites as well as to the benzodiazepine sites. And brexanolone was the first developed. It is approved. It's allopregnanolone, basically. It was studied in epilepsy, didn't seem to work, but it seems to work nicely in postpartum depression, where there is a kind of a sense that these drugs may, in fact, have these patients may in fact have allopregnanolone deficiencies. The first was a 60-hour infusion, so quite dramatic effects on brexanolone versus placebo, as published in The Lancet. And then they do 2 phase 3 trials, small ones, 60 milligrams and 90 milligrams, or placebo and 90 milligrams. And what you see here, the 90 milligrams seems to be the effective dose. And in one study, it did not last. The patients get this for 60 hours to 30 days. And in the other study, it did. And when you put them together, you do see this nice, still see separation as published in The Lancet by Meltzer-Brody at 30 days. So side effects, sedation is a big one. It really looks like it, and it has to be given an inpatient because of the sedation and the risk of falls, etc. So this question of, is it acting as a benzo? So now we have SAGE-217, and here what the development is to try to do 30 milligrams a day for a placebo for 14 days, and then to look at the endpoint at day 15. The side effects, dizziness, nausea, and somnolence, was published in the New England Journal. And what they found, they got nice separation here. But notice here, here you did get this nice separation at day 15, but in the next study, which is the first of the pivotal studies, they got separation at days 3 and 8 and 12, but not at 15. And they could not demonstrate real durability to a month. So the question is this acting really like the brexanolone in postpartum, or is it acting like a big dose of alprazolam? That is and it may very well be that in some patients, maybe the more anxious patients, we will see enduring responses to those drugs, but we need to know, and we need to know what the risk is and how the drug works to interpret what to do.
Excuse me, Dr. Schasberg.
Okay.
My apologies for interrupting you. Just going to give you 5 minutes, 5-minute warning, so that we can have questions at the end from our audience. Thanks.
So I just want to say a few things about MDMA. This is an amphetamine derivative. It produces euphoria, but it's the mellow drug. It produces trust and emotional openness, and people have reported increased bonding between therapist and patient. So people have used it to support psychotherapy. This was, a number of people were very intrigued, and people thought it could be used to enhance psychotherapy. Again, it was sort of, mixed blessing here. There were people who opposed it federally. It was used in certain states. But now there has been opening up to studying it. And what you see with MDMA, and this was the recent paper by Mitchell and colleagues in Nature Medicine, is that with the MDMA, the therapy is enhanced compared to getting a placebo. And it's rather dramatic effects. You can see that on a variety of scores. The Beck Depression Inventory, you can see on anxiety. It's really kind of used for, I think, largely for patients with PTSD. But the drug has another effect, and it's not just this warm and fuzziness. The drug, in fact, enhances extinction and substitute and extinction of untoward memories or whatever. So that, in fact, it's really kind of supports a behavioral modification, a cognitive behavioral modification of the patient's core symptoms. So there we're using it in combination, but we're using it because we have a sense of how, in fact, in animal models, these drugs, in fact, can enhance learning and of new substituted methods for dealing with problems. So it's not just the warm and fuzzy, it's also kind of a memory enhancement. Now, so what does that all mean? Well, it means we really do need to understand the mechanism of action. We need to understand what are abuse liability issues, what are the problems with mind alteration over time. Is psilocybin going to be given once a week, once a month, once every 6 months? We need to understand that to understand the risk benefit. We shouldn't stop studying it, and we shouldn't stop using it if we understand what we're getting into. But just false kind of beliefs that these things are fine is not a good thing for the field, and certainly won't be a good thing for society. We've made these kind of mistakes before with drugs of abuse, unfortunately, in medicine and in psychiatry. So thank you very much, and we got time for a few questions.
Thank you so much, Dr. Schasberg. We really appreciate the broad and deep perspective that you're sharing with us today. I want to remind folks, please, that the chat is open, and we welcome and invite your questions. There are a couple in the queue privately for me, and so certainly go ahead, add yours to the chat, and I will start. I will start with others. Dr. Schasberg, can you comment both in terms of the newer psychedelics, but also even in terms of more traditional antidepressant medications, your views about implementation across the lifespan? That's one of the things we're obviously talking about today. And certainly with brain development across childhood, sort of full adulthood, and then across the aging brain, different benefits and liabilities. Could you give us a 30,000 foot view of your perspective of that?
So there are positive data for all age groups using antidepressants. But there are some groups do better than others. I think that in geriatrics you have a lot of patients that don't really quite show a good response, and in some of the studies you don't see separation. Sometimes it's high placebo response in the studies because the patients are isolated and they're being taken care of or whatever. That's one. But a lot of the late life onset depressions are vascular in nature or have other medical causes. And I think that because of that, we need to have a different understanding of their disorders and come up with better treatments. For the adults, and one thing though that is good, if you look at the FDA study, remember we had this crazy, I think a little bit of crazy, there was a lot of it really pushed by tort lawyers, that these drugs were causing people to kill themselves. You remember that? And the FDA then looked at 100,000 subjects that were treated across all, and they did find some increased ideation and a little activity in 18 to 24-year-olds. But no deaths, which was good. But so some question about it. And so there has been a black box warning on younger people. I think that personally, I don't think that that's been a good thing, because the black box warning, I think, has been associated in studies that have looked at it with increased rates of suicide, in those countries that implemented that warning. But in the geriatric group, those folks kill themselves less than the controls. So in fact, the drugs are having a salient benefit. We just don't have a good treatment for what might be the more vascular depression. So we haven't stopped using them. I think the drugs are effective. I think we just need to come up with alternative treatments, as people have done. And we need to be mindful that all these drugs have side effects. But given the use, let's think about this. Given the use of antidepressants in Western cultures, the number of untoward events with these drugs, pretty small, and often embellished, for other reasons.
And in addition to certainly efficacy rates that you've spoken to and adverse events, what about the arguments or the questions that some professionals and parents alike have about antidepressant use in the developing brain and potential sort of downstream effects, particularly around ultimately wanting, young, either children or anyone under 25, say, under when the brain is still in development and evolving, concerned about long-term effects, difficulties weaning patients off, particularly if the young brain is used to the medication. How would you speak to that?
Well, I think it's a great question, and I think we need to have more data on that. I think first the question of efficacy. There are failed trials of antidepressants in kids. There's no question. And it's not just limited to the SSRIs. You saw this with tricyclic studies. There were very few positive trials of tricyclics in children, other than enuresis or something like that. You had very high placebo response rates. So there is a high expectation bias in the younger kids about maybe the drug will help them. So I think that I think there is a concern about what drugs can do. So far, we haven't really seen negative effects that I think are very clear for the antidepressants. I do think there are certain drugs that are potentially more problematic. The anticonvulsants in pregnancy, the anticonvulsants in kids. There may be issues there. The antidepressants, I think, have a reasonable risk-benefit ratio in kids who are significantly depressed. But the treatment of choice probably for a kid who is significantly depressed probably ought to be psychotherapy first, because if you get a positive response, you probably will have longer term adaptational effects than just drug alone. And certainly probably the best may be the combinations. But I think the psychotherapy plays a very key role in the treatment of children that also can provide us gains by exposing kids to less, because parents aren't rushing to
Right.
expose themselves, to expose their kids to drugs, other than in kids who have behavioral problems and due to attention deficit disorder, where there were kind of really big problems in terms of learning, adaptation in school, et cetera, et cetera.
Thank you. Our next question comes from Karen Cassidy, actually a former ADAA president. What should I expect for my patients who are having a great response to nasal ketamine? It's been life transforming, but your data are alarming.
Well, we will see. I think the long-term outcome study, I think that Janssen has done or is finishing up to understand this better. I think that you see some patients show great responses to esketamine or to ketamine. The question really, there are two questions from my end. One is, do we see tachyphylaxis? I think you see tachyphylaxis with intravenous ketamine, particularly because you get some crazy frequency exposure. Some people give me a lot more and a lot more often, which I think ultimately will just give you tachyphylaxis. So that is one kind of issue. The esketamine, I think, has some built-in, the REMS program and the exposure program builds in a periodicity that I think is helpful. Whereas in the animal studies, those animals were just self-administered, right? I mean, so we're not just allowing people to self-administer. Now, can we get people off? That is a question. And is it that we're having a dramatic, life-changing effect from the Spravato that is in fact giving people an antidepressant effect? Or is it that we have some sort of psychological or dependence, as you see with opioids? You can take an addict off an opioid, and if they get through the bugs and the feeling and the scratching and the itching and all that, 3 weeks out, 4 weeks out, have a profound crashing of their mood. And that's when they're very dangerous because they feel suicidal, whatever. What are we seeing when we try to stop Spravato? And in fact, do we need to keep people on it? It may be that we need to keep people on it. We've done this, right? We have done this with Suboxone. We keep people on buprenorphine because they can't get them off of it, partly because they're addicted, partly because they relapse in their mood and the way they feel. Is that what we have here? Doesn't matter. Maybe it doesn't matter. Maybe, in fact, this is our first shot at manipulating even the NMDA interface with the opioid system. And this is the price to pay. But we don't know if we can get people off. And that is what I think the clinician and the patients want to know, because ultimately the patients really want to get off drug if they can. And we have a lot of people we can't get off drug, but we don't get that rapid kind of falling apart. That is really where I think it gets a little scary, and trying to understand that is what I think we need to do.
Thank you. So Dr. Schatzberg, I want to thank you so very much from all of us, obviously at ADAA and our audience, for sharing your expertise and your wisdom with us and your perspective on these broader questions. I do see we have one other question from Micaiah Kimball Glover that I'm going to pause on because I don't want to eat into the time of our next speaker, but perhaps the panel discussion later can address the very important question of social stigma. How do we address social stigma? Really with these drugs and also with psychotherapy and other interventions. So I'm going to cut us off there. Dr. Liverant, if you're listening, I assume you are, please make a note of that question for our panel Q&A. I'll hold on to it as well. And Dr. Schatzberg, thank you again so very much for sharing your knowledge with us.
Thanks, guys. Take care, guys.
So our next speaker today is Dr. Gabrielle Oliva-Stein. She is a licensed clinical psychologist and professor of clinical psychology at UNC Greensboro. She's associate editor of the Journal of Research on Adolescence and vice president of programming for the Society for Research on Adolescence, SRCD. She also serves on the Ethnic Racial Issues Committee of that same organization, SRCD, and is a past chair of their Latino caucus. Dr. Stein's research uses developmental psychopathology and cultural ecological framework to investigate the impact of culturally relevant factors on the development and psychopathology for minoritized youth and their families. She's been funded by NIMH, PCORI, and NIDA. And really importantly, also, her lab also includes partnerships across the state of North Carolina, and I'm guessing more broadly as well, including school districts and mental health clinics. I would like to encourage everybody, I'm sure Dr. Stein will reference her website and her lab, which is www.caminoslab.org. That's all one word, and I'm going to pop it in the chat because it is just an incredible website filled with free online programming in both English and Spanish. Camino, for those of us who are not bilingual, means path or a road or journey, which is just a wonderful name for the lab and the website. And she also specializes in the provision of therapeutic services to Latinx families and provides training, again, both in English and Spanish, providing such needed information and bilingual access. Her talk today for us is When Discrimination Hurts, Depression in Minoritized Youth. And please, at any point during her talk, you're welcome to pop a question in the chat or the Q&A, and I will curate those for later. Dr. Stein, thank you so much for being with us today.
Thank you so much for having me. And let me just start my slideshow. So thank you. It is such an honor to come and speak with you and speak with folks here about the program of research that we've been doing in the Caminos Lab, but also the work that's been done across by a lot of my colleagues as well on depression and anxiety in minoritized youth. So I want to start by just talking about some of the disparities that we know exist for minoritized youth. There's a lot of different sort of studies out there that really show there's greater rates of depressive and anxiety symptoms for Latinx youth relative to non-Latinx white youth. And this also translates to greater rates of diagnosed mood disorders as well. There is some evidence to suggest greater rates of diagnosed anxiety disorder for Black youth and greater symptoms of depression for Asian and Black youth and Latinx females. So there's a lot to sort of think about that. In adolescence, we start seeing some of these disparities start. And I think as scientists, one of the things that's really incumbent upon us is to understand why these disparities exist. I want to acknowledge that some of these disparities are the result of structural racism that has led communities of color to live in environments that have are not as supportive, right? Lower STS environments, and that is a really important backdrop to understand. I'm going to focus today a little bit more on experiences of discrimination, but we really want to think about what are the roots of these kinds of disparities, and then what can we do to solve them. So I want to start with a quote from a participant in one of my studies. When I was really started my research program of research wanting to understand this disparity primarily in Latinx youth. And I asked parents to think about why is it that we were seeing this greater depressive symptomatology in our community? And this parent shared, in my case, my son, the main problem is feeling discriminated against. It's not that they make racist comments, but the authorities that don't give them the permission to get a driver's license. This makes them frustrated. They feel that no matter what they do, they are not part of this country. And really, the fact that they drop out is not their fault. It is our fault as parents because we bring them here with our documents. But we are here to work, to be good people. But I think this is one of the reasons that they lose their dream. I start with this quote because I think it really exemplifies one of the reasons that this disparity exists, right? is these structural factors like the policies in place that don't let undocumented youth get driver's license, but also this lack of feeling of belonging and this feeling of a loss of a dream. I think it really encapsulates sort of, if you are here, we're sold the American dream, something that's available to all, but we know it isn't available to all. And that fact can really have significant consequences in terms of understanding mental health functioning. So this is where I'm going to start in thinking around how do we really understand cultural risk factors that uniquely influence internalizing symptoms across development. So what are the things do we need to consider when we think about what places these youth at risk? And I'm going to start by talking about discrimination as a stressor. That's primarily what I'll talk about. And for Latinx youth, there's some other stressors I want to address as well, just briefly. So when I talk about this interpersonal discrimination, I mean that by this, I define it as being treated as less than, different than either by your peers or by teachers at school, assumptions made about you in terms of your intelligence, your ability to succeed. For a lot of the peer discrimination studies that I'll talk about today, it is things like hearing jokes being made about your ethnic racial group, not being invited, not feeling a part of sort of the school system that you're engaged in or the neighborhood or where you live. So that feeling that Mom talked about, that lack of belonging, we see in some of these discrimination measures that we'll talk about. In addition to discrimination, a culture of stress is unique for immigrant kids. And this is really where they balance sort of the needing to integrate two different cultures. So pressures to speak their native language as well as English, pressures not to speak with an accent, pressures to understand sort of go across two different kinds of systems in terms of values or ways that are expectation to in behavior, that can be lead to some stress. And then acculturation gaps is something that we've done some work. I'm not going to focus on it today, but if you're interested, I highly suggest you looking into it. But this is really the differential acculturation that happens where youth are perceived as gaining some distance culturally from their parents. And that perception leads to additional family conflict. And that's a host of research that was started in the 1990s by Jose Sapoznik and colleagues really exemplifies sort of how these acculturation gaps can be damaging to families. So what do we know how these predict different outcomes, including depression, anxiety, and as that mom so eloquently put, academic motivation in those times in high school? Well, what we know from some of the research that we've done and I'll cover today is that indeed these cultural stressors predict unique variance above and beyond other types of stressors. So when we think about other things that might be contributing to depression that we know is true and anxiety as well, that we know is true for other populations, these stressors are unique. And so, for example, acculturation gap conflict predicts additional depressive symptomatology above and beyond parent-child conflict. So how the meaning-making process that kids are making around that conflict and that families are making around that conflict contributes to those symptoms of depression and anxiety. And in fact, in a study that we found with parents, we found that moms, the acculturation gap conflict was even more predictive of their own depressive symptoms relative to discrimination. So that cultural distancing they were feeling from their kids was really important. So while it's not, again, a focus of my talk today, I do want to point listeners to that work because it's important to understand that as a unique stressor as well. So I'm also interested, the theme today is across development, across the lifespan. And so how do we know how the discrimination might impact youth across time? So I'm going to talk a little bit about a paper that we published in the Journal of Youth and Adolescence that sort of tested the effects of discrimination across 5th to 12th grade. So what we had known and this is data from the California's Family Project. It was a large data set with 667 Mexican origin youth, primarily immigrant. I'm just gonna flash my samples up so you can see who they are. I'll happy to entertain questions about them in the end. So as I was saying, we understood that discrimination across adolescence had an impact on internalizing symptomatology across time. And so here's the studies that have been done at the time when I did this study, looking at the relationship between discrimination experiences and internalizing symptoms. And we can see from these yellow lines that for the most part, there's evidence to suggest the more discrimination kids are experiencing, the more depressive symptoms that they have. However, if we think about Gilbert Gee's idea of a life course perspective of discrimination, that there may be sensitive periods in which discrimination is particularly harmful. And I was really interested in understanding that across this developmental swath. So was there specific times that increases in discrimination relative to yourself were related to more symptomatology over time? And in particular, for all of us who study kids, transition to school have been one of those types of experiences that have been associated with those outcomes, right? So that we know these transitions can be stressful. And I was interested in understanding, is the transition to middle school and the transition to high school unique time points where that life course, from that life course perspective, would incur additional risk for these symptoms. So overall, what we found, and here's just the the discrimination trajectories from 5th and 12th grade. This is the average trajectory here in black, and we can see just some sort of sample of the different trajectories from different kids. And you can see for the most part, this is in California when the transition to middle school happens in 6th grade, that for the most part in middle school, there wasn't a lot of significant increases in discrimination experiences, but we did see a bump up in high school, and you can see that this kept going up and down across that high school period. So discrimination experiences are changing over time, which is basically the point I'm making here in this graph. But what about this long-term effect? Well, first we found a baseline effect. So kids who reported greater experiences of peer discrimination in 5th grade, by the end of 12th grade, they were reporting greater symptoms of anxiety and depression, and this was controlling for past mental health functioning. So this is a long developmental period, but it highlights the damaging effects of discrimination that can have and be carried across that time span. In terms of timing effects, we actually did find one. We found, or for anxiety symptoms, we found 2. So that after the transition to middle school and the transition to high school, increases in discrimination that were experienced at those points were uniquely related to 12th grade anxiety symptoms and not depression. So this really sort of set the stage to really think about, well, why might that be? Following Mendoza-Denton's idea of race rejection sensitivity, it may be that these youth experience this discrimination and then are worried about it. They're worried about what's going to happen, how am I going to deal with it, how am I going to cope with it in this peer setting. It raises sort of this level of hypervigilance and alertness. There's some evidence to support this idea by some of the daily diary work that has been done by Tiffany Yip and her colleagues in New York. And what they've found is that in daily diary experiences of discrimination were related to next day symptoms of social anxiety. Again, so really just reading that room, what's happening, how am I going to interact with my peers? So that's just an important point to think about in terms of how these symptoms may go together in terms of depression and anxiety. So overall, we know that discrimination hurts. And I want to highlight that the idea of the sensitive period has been shown in a couple of different studies. So there's some evidence to suggest that discrimination is particularly harmful in adolescence. So a meta-analysis done by April Benner and colleagues found that early to mid-adolescence, there was the strongest relationship between discrimination and psychosocial outcomes. Similarly, a study done by Emma Adam and her colleagues found that discrimination experiences in adolescence predicted dysregulated HPA functioning in adulthood, but those discrimination experiences in adulthood didn't once you took into account those discrimination experiences in adolescence. So there's something unique about this experience in adolescence. Similarly, it happens frequently. So a recent study that was published by English and all, Devin English, which was also a daily diary study, found that Black youth reported between 2 to 5 experiences of racial discriminations a day. So this is happening a lot, and kids are experiencing a lot. And it has long-lasting effects. So the study I just showed this long-term effect up until 12th grade. And there's lots of different mechanisms that have been suggested, including biological mechanisms, like I mentioned, as well as psychological mechanisms. So it's really important to think around discrimination as a unique stressor that's sort of leading potentially to some of these disparities that we're seeing in the literature. So, sorry about that. Make sure I can go forward. So then that really begs the question of how do we understand then how to support families and kids who are having these experiences to mitigate the negative impact of discrimination on these mental health outcomes? And how can we understand them in conjunction with what we already know about risks for depression and anxiety? So I'm going to talk a little bit about some of the work that we've done looking at the link between discrimination and depression, and looking particularly at what are sort of considered culturally universal kinds of risk factors or protective factors in terms of discrimination, in terms of stress to depression link. So cognitive appraisals and coping. So I'm going to start by talking about another paper we published in the Journal of Youth and Adolescence, testing attributional style as a unique sort of risk factor. And really what we were interested in understanding was, how did attributional style serve as a risk relative to other types of stressors that we know are associated with depressive symptomatology? So we know that an attributional style, right, those internal, stable, global attributions about the self can serve to increase risk in the face of stress. And here we looked at economic stress and parent-child conflict, and we also looked at peer discrimination and acculturation stress. Again, this is a sample of a primarily Latinx youth, 7th to 10th grades. It was a cross-sectional study where we did some work in, again, primarily immigrant kids and immigrant families. So what did we find? So the first thing I want to highlight is both parent-child conflict and economic stress was associated with greater symptoms of depression. And oops, I don't know what just happened. Oh, there we go. Can you see that? I can't see that there, but I think you all can. Yeah, I think something happened. Is it blank for you all?
It is.
We can see it now we can see it, Dr. Stein.
Okay, so let's see if I do that, if that works. I don't know what's going on here. Let's see if I go to this one. Okay. Well, my boxes are not here, but I'll just circle. So here we go. You can see that discrimination was a unique predictor above and beyond, but not acculturative stress. And in part, that's because acculturation stress, we're not the only folks that find that the discrimination is the main driver of acculturation stress and its link to depressive symptomatology. So what happened with this attributional style question? Well, we did find, consistent with the sort of the model of the hopelessness model, was that attributional style was a risk for kids facing higher levels of economic stress. So you can see that here. So we did find that significant moderator. We didn't find that for family conflict, for parent-child conflict. However, attributional style was not a significant moderator of discrimination or acculturative stress. So so while attributions might be really important in understanding how discrimination links with depression for other types of life stressors, in this particular model, it didn't come out. So we asked this question in another sample. Oh no, now it did it. This is so strange. I don't know what is going on. Okay, so so this is another paper that we published in Developmental Psychology that was looking at the same kind of question. We were interested in understanding the impact of peer discrimination and adult discrimination on depressive symptoms as well, and trajectories. And here I want to highlight that we were looking at peer and adult discrimination differently, because some research had suggested that adult discrimination is more associated with academic outcomes, while peer discrimination is more associated with mental health outcomes, particularly depression and anxiety in youth. We tested again whether attributional style was a moderator, and here we were interested in understanding, is it concurrently and longitudinally. We were also interested in emotional reactivity, so that sort of feeling sort of sense of anger and distress, sort of what would the role of, if you were prone to having higher levels of that reactivity, would that serve as a risk factor? And then here we started looking at another factor that we'll talk a little bit more about in a bit, ethnic racial pride. So one of the things I really want to highlight today is that what's really important to understand how we protect youth of color around experience of discrimination is that we're really going to have to integrate what we know about depression and anxiety more broadly with culturally relevant and embedded risk and protective factors. So here is this sample, and this sample was 155 Latinx and Black youth. It was about 50-50 African-American and Latinx youth. And most of the Latinx youth were US born, but a large chunk of them were also foreign born. Okay, so let's go. Okay, so what did we find? So here we can see, so I want to just sort of highlight here that peer discrimination and adult discrimination were both cross-sectionally related to concurrent symptoms of depression. This was at the start of 9th grade. And we did find this differential effect in which peer discrimination, so increases in peer discrimination over time, were associated with greater increases in depressive symptoms over time, but that we didn't find that effect for adult discrimination. So that's again suggests that these interpersonal stressors that are peer-based may be more predictive of this kind of internalizing pathology, as had been found by other research teams. In terms of the moderation, again, we did not find that attributional style moderated either the cross-sectional link or the longitudinal link for depressive symptomatology. So I think one thing I want to really highlight here is that these attributional style measures were developed primarily with white youth and didn't specifically ask about discrimination. So one thing that I think is important for our future work to do is to, when we think around some of these cognitive factors, that we really think about how we measure. And so if we use just generals to say, I tend to look at things in this way, as opposed to specific to discrimination, I think it's my fault. That's a different kind of attribution. And so I think measurement really isn't going to need to sort of disentangle that. And I think that's why we're not finding this effect here. Emotional reactivity was a significant moderator. So meaning that kids who had a tendency to get angry more easily, to get more distressed, and to have a hard time calming down, those kids were more at risk when they experienced discrimination cross-sectionally. So those period issues of discrimination led to potentially these increased affective experiences, and that distress then carried on to more depressive symptoms over time. I also want to highlight that ethnic pride and affirmation had a longitudinal protective effect. So for those kids who started high school feeling connected to their group, feeling a high sense of pride and being a member of their ethnic racial group, those kids were better able to weather those discriminatory experiences over time. And they didn't show that longitudinal link that I showed that we saw for other kids. So this together really thinks about how we want to bring together risk and protective factors in families of color. So I want to highlight here work that was done by Enrique Neblet, Debbie Rivas-Drake, and Umanya Taylor that really did this piece in 2012. They really argued that to understand this discrimination to adjustment link, we need to think about these culturally informed promotive and protective factors, including ethnic racial identity, which I just sort of highlighted, again, that sense of meaning of your group, belonging, affirmation, and pride in being a member of that group, your cultural orientation, so the behaviors that you're engaging in that are consistent with your group, things like your values that you're endorsing, the traditions that you're upholding, taking part in sort of events and activities with members of your ethnic racial group, and ethnic racial socialization, which I'm going to talk about at the end, which sort of just conversations that you're having in your home about race and ethnicity, and how these interact with things like self-concept, attributional and cognitive appraisals, and coping strategies to together lead to sort of better outcomes for youth. And so this is what we're going to focus on for the rest of the talk. How do we put these together? And what are ways that we can think about where this resilience comes from? So this first talk, this first part I'm going to talk about, I'm going to focus on this sort of need to draw on multiple cultural strengths at once, so that while ethnic racial identity was protective long-term, it wasn't concurrently protective, right? So what are the other things that you might need to draw on to experience this added boost? So so this was a paper that we published in the Journal of Research in Adolescence that looked at this, that was led by Allison Kavanaugh. And here we looked at this sort of idea of these multiple cultural assets that you need to have on board to counter this detrimental effect. So ethnic racial identity, like I mentioned, sort of this connection, sense of pride, how central ethnicity and race is to your self-concept and how you sort of understand yourself. Familism values are something that has been studied primarily in Latinx populations. And these are values around the honor, the obligations you have to your family, the need to support your family no matter what, and really defining yourself in relation to your family. I do want to highlight that although the familism literature has been primarily done with Latinx communities, there's some emerging evidence in African-American communities that it's protective, some work by Margaret Coffey, as well as some work by Chiang and colleagues up in Chicago that have found that familism offers some similar protective effects in Black communities, as well as cultural knowledges and practices. So this idea of being embedded in your cultural group. So when you have pride in your identity, are you doing things and feeling connected to your group? So that's those cultural orientation pieces that were in the Neblet model. So what did we, so this was, sorry, I always want to go to what do we find, but I'll tell you who's in the sample: 176 Latinx youth in 7th and 8th grade, again, primarily immigrant with parents who were mostly born in Mexico and kids who were mostly born here. So here, all my pictures involve arrows that go in two different ways. So we tested both the promotive effects, right? So how did these cultural assets lead to better outcomes in these teens? Again, we looked at peer discrimination and adult discrimination differently for the reasons I mentioned. And here we actually added a measure that had been recently developed at that time on foreigner objectification. And so this is the idea that if you're Latinx or Asian American, that because you're perceived as perpetually foreigner, that's going to lead to a unique sort of experience of discrimination where you're told things like get out of this country, assumptions are going to be made about where you were born, your language ability, things of that nature. So the foreigner objectification is a unique aspect of discriminatory experiences, which is a little different than being treated less than or differently. Both damaging, but important to understand their different impact. So we were interested in this cultural asset model, and was that going to lead to some better outcomes? And was it going to actually lead to this protective effect, this moderation effect, so mitigating high experiences of this stress? So what did we find? So I know this is a lot of boxes and pictures, so just follow the bolded lines. So peer discrimination was associated with both internalizing symptoms and externalizing symptoms, as well as foreigner objectification. So I want to highlight that school adult discrimination was not associated with any of these outcomes. Again, sort of similar to the work that had been suggested, but we were surprised that it wasn't associated with academic motivation because some prior work had shown that. We did find a promotive effect of these cultural assets, both to academic motivation and for externalizing symptoms, but we didn't find it for internalizing symptoms, which is what we're here to talk about today. So clearly there's maybe more that's needed on board. We did find a significant moderator for these high cultural assets that completely mitigated the experience of peer discrimination, as well as foreigner objectification on externalizing symptoms, both self-report and mother-reported of those symptoms. So these cultural assets are doing something protective, which is great. It's good to know that these resilience factors are working, but not for internalizing symptoms. So this really led us to think about coping and bringing in coping into this model and really thinking about how does coping coalesce, similar to what was suggested by Enrique Neblett and colleagues, right? So how do these come together to promote positive outcomes? Okay, so I'm going to start with a couple sets of studies, and these are led by a former student, Kata Christoph, who's now a professor, an assistant professor at Wake Forest University. And so this first question, we were really interested in looking at coping in this very unique lens. So Edith Chen and Greg Miller had proposed a unique constellation of coping factors that were particularly well suited for kids experiencing high levels of socioeconomic stress. And they really argued that because socioeconomic stress is uncontrollable, that primary coping strategies were not going to be effective to deal with that kind of stress. So they argued that there would be both physiological and psychological benefits of focusing on secondary coping responses, particularly around shifting away from the stressor. So this cognitive shifting, being able to reappraise stressful situations and move sort of away from that, and at the same time, connect to things that provide you with meaning and hope in the world. So the things that give you sort of a sense of optimism, a sense of support, a sense of sort of meaning and purpose, and that through the constellation of those two, the shifting and the persisting, that would be most effective to deal with uncontrollable stressors like poverty. And generally, what they have found, they tested this question primarily, and this is from health psychology, with a bunch of different physiological and health outcomes, and found it to be the case that greater levels of shift and persistent coping led to reduced inflammation in the context of high or low SES and economic stress, better diurnal cortisol, lower BMIs, better experiences. So primarily they had looked at this from a SES perspective, but they did have one study that was done looking at discrimination, where they did find that it also served as protective against discrimination for asthma outcomes. And this was a longitudinal finding. So they proposed that shift and persist is helpful in terms of both physiological and psychological coping and functioning. And they tested it primarily with health outcomes, but it hadn't been tested with mental health outcomes, even though they proposed that the similar mechanism would be in place. So that's what we aim to do. And again, with that La Familia data set that I presented a little bit, I don't think I had presented earlier, for these are 7th and 8th graders. So what we were interested in understanding was that did shift and persist coping work in the way for economic stress in the same way that they had proposed, but for a mental health outcome, depressive symptoms? And we found that indeed it did. So that, as you can see, this attenuated risk that at low levels of shift and persist, you have higher depressive symptomatologies, but it's less, it's mitigated for kids with high levels of shift and persist here. So you can see that these kids have lower depressive symptoms than those kids who were had lower shift and persist. So this was the first study, and to our understanding, and this is in a Latinx sample, that showed this effect. So we were then interested in taking that and thinking about it in the face of discrimination. And in particular, we were really, what we thought would happen was that these shift and persist processes would be most effective for kids who had high levels of ethnic racial identity, similar to that pride finding that we had in that longitudinal paper. And that it was coupled together, shift and persist and ethnic racial identity would come to help mitigate that negative impact of discrimination on depressive symptoms. But well, we found a three-way interaction. It was not in the way that we anticipated at the time. So as you can see here, that shift and persist was actually protective for kids with low levels of ethnic racial identity. So those kids who had low levels of ethnic racial identity reported higher levels of shift and persist in the face of discrimination, did not show the same negative effects in terms of depressive symptomatology. However, at low levels of shift and persist and low levels of ethnic racial identity, discrimination actually was predictive. Here you can see for kids with high levels of ethnic racial identity, you basically see this main effect, right? That discrimination led to more depressive symptoms regardless of your level of shift and persist. So we were very puzzled by this finding. We really thought it would go the other way, but what it really highlights is that this constellations of what's going to be important and protective in the context of discrimination may be different for different groups, depending on your ethnic racial identity. So we went back to the California Families Project data because they also had measures of shift and persist. And we thought, okay, well, why don't we see if this is the same? And we find the same kinds of findings in a completely different sample, larger, and looking at depressive symptoms over time. So this is we also found the same three-way interaction, and this is a very complicated slide. And I want to say that most of the action I'm going to talk about is really the concurrent effects at 9th grade. But basically what you see is that for kids who experience, who had high, high levels of low levels of discrimination. I'm sorry, that got cut off here and I can't see. So these are kids with low levels of discrimination. They basically didn't have as many symptoms of depression, right? So those depressive symptoms that we saw, those discrimination depression link, right, is something that we see here. And in particular, I want to highlight this. Those kids who had low levels of ethnic racial pride and high shift and persist, so similar to what we found in our other paper, were in this blue box. They did not have that same link between discrimination and depressive symptoms. However, for kids who had higher levels of ethnic racial pride and high levels of discrimination, they did have this additional depressive symptomatology. So these are these two bars here. So these are kids at high levels of ethnic racial pride, and shift and persist did not make a significant difference between these two. However, who did look significantly different was this yellow line here. So those kids who had the lowest levels of ethnic racial pride, the lowest levels of shift and persist, were the kids who were the worst off. So we found this now in two different samples, that when you had high levels of ethnic racial pride, which most kids have, the discrimination is still leading to some of these negative internalizing symptomatology. So this led us to really think about, what does shift and persist really look like in communities of color? And what are ways that they may be able to draw hope and meaning and sense of purpose and cognitively disengage from that stressor. So we really turn to some culturally relevant coping factors that might be really important to incorporate. So based off the work of Alon Hope out at NC State, we really thought that critical civic engagement was going to be an important sort of way in which kids would be able to cope out of their experience, sort of shift away from that experience of discrimination and engage with others in activism, right? Engage in sort of dismantling racism together with other folks that had similar kinds of experience with them. And that would give them some optimism and hope that potentially these systems could be dismantled, as well as sort of a sense of efficacy and a sense of meaning and purpose in their lives. And we also felt that based on the long history of resilience in terms of spiritually based coping, that this would be something important to do. And this is similar to the work that's done by Daniel Lee, Meredith Hope, so Sharita Butler Barnes, that are showing these kinds of spiritual-based coping as important at mitigating the negative impact of discrimination on internalizing symptoms. So we were really interested in understanding how did this come together with shift and persist. And did this sort of, it's like being able to cognitively shift and persist and engage in these culturally relevant coping factors, would that be most protective? So that's what we were interested in understanding here. And in particular, would this be where the kids with higher levels of ethnic racial identity able to engage in those kinds of coping mechanisms would be able to draw on that? So this is a sample of 364 minoritized college students, primarily Black students, with a fifth of the sample Latinx and a small portion Asian American, again, primarily US born, and most of them were 18 because it's a college psychology pool. But what did we find? So first, I want to say that we did find evidence of this higher order shift and persist culturally engaged coping factor. And discrimination was associated with more depressive symptoms as we thought. But culturally informed shift and persist was associated with fewer depressive symptoms. And in fact, we did find this significant moderator. So for kids who had highest levels of this culturally informed shift and persist, when they experienced high levels of discrimination, they did not have that same level of depressive symptomatology. So it was protective for those folks. And this was irrespective of their ethnic racial identity. So for both high and low centrality and pride, sort of feeling connected and connected to their group, those were just as protective. I also want to highlight that ethnic racial identity was associated with greater use of culturally informed shift and persist, so that these are indeed coming together to support youth. And this may be the way that ethnic racial identity is supporting that protective effect that we want to see. Similarly, I also want to highlight that ethnic racial identity is also associated with greater experiences of discrimination, right? Because you're seeing the discrimination that's out there, because you're understanding yourself in this way and seeing what's there. So that's a really important sort of piece of information to really think about why this is such tricky work to do, is that when you're connected to your racial group, you understand the discrimination that your racial group faces, but then how do you then cope with that discrimination? And our findings here would suggest that taking together these spiritually based coping, critical civic engagement, the ability to shift and persist are really important. And these are wedded to your understanding of yourself and your identity. So this then leads us to think about, well, what is it that helps kids have that, right? Have that resilience, have that sense of connection to their group, have those abilities to cope and deal with the discrimination. And I want to highlight that what's, I think, really important to help kids understand, right? We had that emotional reactivity finding, we had that finding with the anxiety symptoms, and we would look at Rihanna Anderson and Howard Stevenson's recast model that really highlights the sense of coping efficacy, that kids are able to read racialized moments and then enact coping skills to deal with those, to help reduce that anxiety, that depression, that emotional reactivity, and feel empowered in their communities. So this really leads us to really thinking about how does ethnic racial socialization comes in. So briefly, for those of you who are unfamiliar with this term, ethnic racial cultural socialization is sort of the conversation, and this primarily has been studied from parents to kids. So these are the conversations, this is what families of color are doing to protect their kids and to help their kids thrive in a system that was not meant to help them thrive, right? In a system replete with racism and discrimination. And for most groups, right, cultural socialization is this sort of notion of teaching your cultural values, your history, your customs, as well as pride in your group. These positive messages about being proud of being who you are. This is the unique contributions of our group to the US society or to greater society, and really embedded in that sort of strength and cultural resilience. Preparation for bias messages are those that raise awareness about discrimination and prepare youth to cope with those encounters of discrimination. And these have been primarily the most studied. Promotion of mistrust messages are those being wary when interacting with members of the dominant group. And egalitarian messages are those that emphasize equality and those that emphasize that we're all sort of that we should treat everyone the same. Sometimes these could also veer on the side of colorblind kind of messages that race doesn't matter. And both promotion of mistrust and egalitarian messages are not very well studied, even though these are delivered, especially egalitarian messages are delivered by families. So we still need a lot more work to do that. But I want to highlight for the most part, what we know, this is a recent meta-analysis that was done by Adriana Umania Taylor and Nancy Hill. And what they find generally is that these cultural socializations messages are very promotive. So if you look at across families of color, the more you provide these messages to your kids, the better off your kids are. So for the most part, these are very promotive kinds of messages. And these are the numbers of studies in their review. However, preparation bias for messages aren't always promotive. There's a lot of null findings or mixed findings that come with that. And you can see a lot of more show some risk. So we still really need to understand how to provide those coping efficacy skills that are suggested in the recast model. How do we provide kids with the ability to cope with discrimination, let them know it's going to happen, but also help them feel empowered to have those conversations and to be able to cope with the experiences of discrimination that they may encounter. So that's going to lead to this next part, which is sort of how we are going to help think about how to do that. So just watch this short video with me for a second.
Unfortunately, we live in a society that sees your race or ethnicity first before they get to know you.
Por ejemplo, yo voy manejando, un policía me puede parar solo por mi color, por ser latino. Eso es lo que para mí significa ser latino en este país. Miedo.
When you're younger, you really want to fit in. I know when I was a child, even around my daughter's age, I think there were times when I didn't want my friends to come over to my house because I just thought it was just too different.
It's really about preparing them to be independent people, independent thinkers, and to find their voice, which is going to be different from mine and their mothers, but to not be afraid of that.
I don't feel like I had a lot of conversations with my parents about race, ethnicity until I was much older. I'm motivated because I don't feel like I had enough conversations like that when I was his age or growing up.
Una Plática a la Vez es un programa que hemos desarrollado para fomentar las conversaciones difíciles y a veces valientes que uno tiene que tener con sus hijos.
We hope to empower parents to have these courageous conversations.
By avoiding it and not talking about it, you're talking about it, whether you think it or not. It's okay. We all struggle with this. And here's some tools to help you to get through it. And we'll do it together.
So this is our one talk at a time intervention that we've developed to help. This is along with Dr. Stephanie Irby-Cord that you saw there and Dr. Lisa Kyung, as well as Dr. Laura Gonzalez, that we've developed to sort of support these conversations. Sort of that what we really saw from that literature is that part of what makes these messages so hard to deliver, right, is sort of the content, the climate of these messages that you give, and those mean that coping efficacy to deal with that anxiety, that negative affect, the distress that you're getting. So this is a intervention that we've developed to deliver completely online. What families watch is a short little video, and then they answer a few types of reflective questions to help to tailor these kinds of conversations to their families. So we don't tell families exactly what they should talk about, but we're really hoping to foster parents' efficacy and sense of ability to give and deliver these messages in order to then be able to engage in these conversations with their kids. We then do some skill building exercises and do some modeling. So in the first part, we have 3 sessions that are focused on psychoeducation. Again, we talk about the goals that they have for their kids, how to meet those goals, identify barriers to these conversations, and primarily for preparation for bias conversations. We see that families tend to have these conversations much later. So typically in late middle school. And as you saw from that first finding, I pointed out that by 5th grade, these are having a significant impact, and even much earlier than that. So we really want to help families have these conversations in a developmentally appropriate age earlier on, because parents are scared it's going to be overwhelming for their kids, or they're upset themselves and they find the conversations really stressful. So we sort of help them identify what makes these conversations difficult for them, reflect on these conversations, and then identify which ones how they want to move forward. We then teach them the ready, set, talk skills, which are about how they're going to be able to engage in these conversations. So ready, really focused on the parents. Sort of what messages do they have? Do they want to deliver? What are the barriers that they have, and giving them specific strategies for those barriers, giving them sort of a way to give these conversations in a developmentally appropriate way. The set component is setting these conversations to your particular kid, right? Is your kid someone who's prone to get upset or a jokester? So their temperament, as well as thinking about things about themselves like gender identity, their skin tone, do they have an accent, immigrant status, things like that. And then what context are they in, right? Do they go to a primarily white school, or are they primarily surrounded by folks of their own racial group? Like what about their after school activities, things like that. So setting these conversations to their kid and the context that they live in. And finally, the talk skills are those skills at the end, which are just very like following their child, listening to their child, having a conversation with their child about these kinds of topics in a child-directed way. And then we really emphasize in the talk portion, role-playing with their child and building a sense of coping efficacy. Then when they see families have these conversations. So I wanted to highlight that these are we have three different kinds of interventions here, for Latinx families, for Asian families, and for Black families. And then you're able to watch those families have these conversations, see what that's look like. So they see 4 different conversations, and then they reflect on what those families were doing. We provide a set of different pieces of sort of ways to practice. We give them, again, some of these developmental kinds of pieces. We give them a lot of different resources that they could use to have these conversations with their kids. One of the things that research finds is that parents think by just like having the books in your house, that's enough. But we really talk about having the books and then fostering these conversations with your kids. And how do you have this conversation with your kids? So we give them a lot of different resources about books, movies, TV shows they can watch and do together. So we've piloted this intervention with 15 families, and indeed we found that this intervention did help families feel ready to have these conversations, particularly around cultural socialization and prep for bias. They were motivated to have these conversations, and they were planning to use this skill set. We also interviewed these families, and they shared generally the importance of the work. So reflecting on the videos fostered the opportunity I see as a parent. I have to change. Building pride in your heritage, preparing against biases. That focus is good, simple, and easily applicable. This parent had also said that they thought this wasn't something they needed. And once they watched the videos, they realized how little they had actually had these conversations in an explicit way with their kid. And then here you see an African-American said, great program, more people should be exposed to it. We often do not realize how much our kids are impacted by race and ethnicity. So I started out talking about the loss of dream that parent shared with us, and that loss of dream, and we're doing everything we can to sort of figure out how to help kids reach their dreams, right? Are the ways that we can arm them to cope with an environment that wasn't necessarily built for them, so that they can feel optimistic, they can thrive, they can find meaning and purpose, and that they can continue to sort of mitigate these negative impacts of discrimination on their outcomes. So I'm excited for your questions and to talk more with you today. So I just want to thank my many people that have led to this work, collaborators, postdocs, graduate students, obviously the families and the schools that have partnered with me in this work. So I appreciate your time, and I'm excited for your questions.
Thank you so much, Dr. Stein. It's just fascinating what you're doing, and you know, I stammer at the sort of vast implications of this for kids and adolescents growing up, obviously Latinx community and so many other communities as well. And I often find myself thinking like, wow, I wonder what life would have been if I grew up now instead of in the 80s, when nobody addressed any of these things. So I think this generation is really happy to be really lucky, excuse me, to be the beneficiaries of all of this effort and work. A number of questions. I'm going to start on a clinical note. What would you recommend as people, as clinicians and practices integrate a myriad of additional questions into standard intake forms? And we've certainly seen that with gender, appropriately with gender, identity, and sexual orientation. What would you recommend if you had to recommend 1 to 3, say, questions to be included routinely, standardly in terms of history of discrimination or other relevant, other related factors? What would your advice be on that?
Yeah, that is an excellent question. So I think one thing is assessing for race, ethnicity, what cultural groups they're a member of, not making that assumption. So that's a really important piece, and really distinguishing race and ethnicity is important. So the sort of how did the groups that, to what ethnicity mean, groups that they share values with, identity with, that are important to them. I actually agree with you. When I was in training, I was not trained how to assess for discrimination, right? That wasn't something that I generally asked or was told to ask. So that is something I think we should do in all of our intakes, is ask sort of, and I think the DSM-5 cultural interview does a really nice job, has a couple of really beautiful questions in there about what are important aspects of yourself that you want to share with me. And they give a long definition. And have you been treated differently because of this aspects of these pieces? And giving that list of race, ethnicity, cultural group, religious orientation, sexual orientation, gender identity, because a lot of times it's sort of like PTSD. If you ask someone, do you have trauma? They'll say no. But if you say, oh, have you been sexually assaulted? They say, oh, yes, I was, right? So very similarly, we don't want to just say, have you experienced discrimination? Because people may say no. You really want to ask, have you felt like you've been mistreated due to your an aspect of yourself, of your identity? Do you feel like you haven't gotten the opportunities that you wish you had? And then the other recommendation I'll make is around the cultural values that are important to them, right? So not making assumptions that certain groups have different cultural values, but I think assessing for spirituality and familism values is really important, not assuming that that's important to that particular client, but asking them about that, I think would be really key.
Amazing, thank you. Similarly, you talk about, I just love shift and persist. I think many of us are going to be using that continuously now. Can you speak to what existing treatments sort of naturally already incorporate, even by a different name, that notion of shift and persist, or what sorts of treatments you'd like to see developed to do so?
That's a great question. So so one thing I wanted to say is that we're actually working on a paper taking the Neblett model to clinical interventions with kids and adolescents for an invited in the Journal of Clinical Child and Adolescent Psychology. So be on the lookout for that. But because you're right, most of our treatments that have been developed, particularly for depression and anxiety, don't have specific things to say, how do you incorporate discrimination as a stressor? How do you incorporate unique kind of coping, the shift and persist kind of perspective, the culturally relevant kinds of factors in terms of bringing that in? So I don't think as a field, we've done a good job of necessarily thinking around that, particularly around things that give kids a sense of meaning. So ACT is probably right, when you have values and how you behave consistent with your values is what I think is the most consistent. But I think really thinking about it in that way, I think we can do a better job of developing that. Rihanna Anderson and her colleagues have developed an intervention for clinicians on racial socialization that I would recommend, called Embrace. So folks should look that up. And that is a clinician-based kind of intervention that has some of these sort of racial socialization components about how to cope with kinds of discriminatory experiences and how to promote those conversations with kids.
Thank you. So we have a number more questions, and unfortunately, we're only going to get to a couple of them. Can you speak about, I'm shifting gears back to the more empirical, away from the clinical. Can you speak to the differences in levels of depression and anxiety between immigrants and those who are US born?
Yeah, that's a great question. The literature isn't clear on that. So some studies find that there's a risk that is greater in recent immigrants. Some literature finds that it's greater in US born kids. Generally, there's an immigrant paradox in which the folks that we think are the most at risk are the immigrant kids. And sometimes we find that that's not the case, that native born kids, for lots of different reasons, structural racism that it's existed, may have additional risk. And the literature really is equivalent on this. So some studies show more risk, some studies show less risk. So I actually don't think we know the answer to that question. And I think it just really depends on the context where those kids are living.
Thank you. I'm going to get in trouble for this, but I'm going to pass along one more question. Can you talk, sorry, I'm going to speak to this. Okay, in honor of the Spirit Day, can you speak to the sexual orientation in conjunction with race and levels of discrimination and depression and stress?
Definitely. So we just did an analysis that showed the greater kinds of identities that you have that are marginalized. Like LGBTQ plus youth, the greater experiences of discrimination you have, which isn't surprising, right? There's more ways in which, so intersectionality makes like it shapes your experience of oppression, but it also shapes the types of discriminatory experiences you have. And particularly for youth of color, LGBTQ youth plus youth of color, there's other sort of risks that come from them within groups, sort of not feeling that sense of belonging within group, and then within the LGBTQ plus community, where they might experience additional discrimination, so that they're navigating multiple areas that make it a little bit more challenging for them.
Thank you. Well, Dr. Stein, really fascinating and important work. So I thank our audience members for their questions, certainly you for your expertise and your vision on this incredibly important topic.
Yeah.
Thank you.
And I also want to give a shout out. I wanted to say Sean Jones, who's on your panel, Lex, has a really great paper that's just looking at a life course around coping and discrimination in Black communities. So I highly recommend that paper as well.
Thank you for that.
You're welcome.
So we are going to shift. We're running very close to on time, so we're excited about that. I'm going to introduce our panel discussion now. The topic of our panel discussion is going to be innovations in transdisciplinary treatment for depression across the lifespan. Our panelists include Drs. Namki Choi, Sean Jones, Gabrielle Liverant, and David Michulan. And Dr. Liverant today is chairing for us the panel. In addition to being the chair of this panel, she actually chaired our organizing committee for this entire event. When she's not doing that, she is a clinical psychologist and associate professor of psychology at Suffolk University, where she was formerly the director of clinical training. She's former chair of the ABCT Academic Training Committee, and as I mentioned, chair of this event. Her research is centered on identification of shared etiological mechanisms that underlie mood, anxiety, and trauma, and stressor-related disorders, and the translation of that into more effective therapeutic interventions. So thank you, Dr. Liverant, for chairing for us today, and welcome to all of our panelists. Thank you.
So welcome everyone to the panel section of our virtual Fall Forum today. I am going to share my screen just briefly with a few slides to get us started. So as Barbara was saying, welcome to our panel, which is focused on innovations in transdisciplinary treatment for depression across the lifespan. I am thrilled to be chairing our panel discussion today. And in a moment, I'm going to invite our panelists to give a brief introduction to themselves and their areas of expertise. And this will include a description both of the focus of their research as well as their clinical activities. But before I do that, I want to just give our audience members a brief overview of what they can expect for the format of our panel today. It's going to be broken up into two pieces. In the first part of our conversation, I'm going to be moderating some guiding questions for our panelists. And then we also will have a Q&A with the audience. So we are hopeful that you will post your questions in the Q&A function or in the chat box. And Dr. Kamholz will be helping to moderate those questions as they come in and then during the Q&A. So I'm going to start us off with introductions, and I'll thank Barbara for her overview. So as Barbara mentioned, I am Gabrielle Liverant. I am a licensed clinical psychologist and an associate professor in the psychology department at Suffolk University. I am the recently retired director of clinical training for our clinical psychology doctoral program at Suffolk University, and I'm currently in the role of associate director of clinical training for our program. In addition to my academic roles, I also maintain a private practice, so I'm actively engaged in clinical work. In terms of my research, as Barbara was saying, My laboratory-based mechanism-focused research examines transdiagnostic factors that influence both the onset, maintenance, and then treatment of mood, anxiety, and trauma and stressor-related disorders. Specifically, my research focuses on learning mechanisms, for example, reward and punishment-based learning, and emotional reactivity deficits or changes, such as anhedonia across these disorders. I'm looking forward to both moderating our panel today and also serving as a contributor. So with that said, I'm going to invite Dr. Choi to introduce herself again with a description of some of her areas of research focus and then sort of clinical applications.
Yes, thank you. Hello, my name is Nam-Ki Choi. I'm professor at the Steve Hicks School of Social Work at the University of Texas at Austin. I'm a gerontologist, and my primary research focuses on improving access to depression treatment for low-income homebound older adults, especially in aging service settings. So homebound older adults suffer from depression at almost 3 times higher rates than non-homebound older adults. However, the antidepressant medications are not really effective for them, as their depression tends to stem from multiple health problems, chronic life stressors, competing life demands, financial stressors, and social isolation, loneliness. And a lot of these people are taking multiple drugs. So there are some pharmacological effects. So I work with Meals on Wheels organizations because they serve a large group of low-income homebound older adults. And I will talk a little bit about how to use the lay counselors, bachelor's level counselors, because there are just a shortage of geriatric mental health clinicians. So my research is really testing real world effectiveness of these lay counselors who are embedded in Meals on Wheels or other aging service settings.
Thank you, Dr. Choi. We're thrilled to have you with us today, and we're very excited about the range of perspectives that we have on the panel. With that said, I'm going to turn it over to Dr. Jones and ask him for a brief introduction, both of his research areas and then clinical applications.
Absolutely. Thank you so much, Gabrielle. And it's such an honor to be on this panel. It's such a distinguished set of co-panelists. So as you all can see on the screen, my name is Sean Jones, and I am an assistant professor of counseling at Virginia Commonwealth University. A bit about that. So I'm actually trained as a child and family clinical psychologist, though I reside in that program. I think by the end of my time, that connection will become more crystallized and clear. And so as a background as a child and family clinical psychologist, my research interests really are examining a lot of what we heard for those of you all who were present for the second of our wonderful talks this morning, and really looking at the intersection of race, ethnicity, culture, and mental health. And so particularly what our work focuses on is really kind of challenging narratives of resilience, psychological, psychosocial resilience that includes depressive and anxiety symptoms, but also extends to other symptom settings, as well as indices of well-being for Black youth and Black families. So predominantly looking at racism-related stress as a pernicious stressor in the lives of Black families, and looking at factors such as racial socialization and racial identity. So again, if I sound like you just heard that before, you heard something similar, and as well as culturally relevant protective factors. And so the research that we employ at VCU as a part of our AYA research team really looks to kind of harness the strengths within the Black family to promote resilience, resistance, and whole and healthiness within those settings. the way that that manifests for us clinically and is relevant to our conversation today is really thinking about and I know we'll talk about this more, but thinking about ways in which general stressors or general kind of maladies really intersect with these kind of racial and cultural factors to really kind of be a double whammy for Black youth. We're seeing some recent research on depression and suicide rates in Black youth. And so that is concerning to us in the work that we do. So we think about how do we take what we know in kind of the research side of things and think about how we can extend those into the development of preventive interventions using Black children, using Black families, using those folks in concert together to really disrupt some of kind of the deleterious pathways that we're seeing. So happy to talk about that more, but happy to be here.
So thank you, Dr. Jones. We're definitely going to ask you to talk about that some more in just a few minutes. And again, we're thrilled that you were willing and able to join us for the panel today. Lastly, I'm going to turn it over to Dr. David Michelon for an introduction to his work.
Thank you, Gabby. Also very honored to be here. If I sound a little hoarse, it's because I'm battling an upper respiratory infection, but fortunately it's not COVID, it's a common cold virus. So I'm David Michelon, and I'm a psychiatrist at Massachusetts General Hospital, and I'm the director of the MGH Depression Clinical and Research Program. Historically, my research interests have focused on complementary and alternative medicine and their applications in the treatment of depression. I've studied various natural remedies, for example, omega-3 fatty acids, SAM-E, and St. John's wort. And I've also studied various mind-body interventions, for example, acupuncture, yoga, and mindfulness-based cognitive therapies. In addition to research, I'm also a clinician, and my clinical and research work has focused primarily on adult populations. Since becoming director of the depression program in 2017, I've also had a hand in many more projects that are being pursued by people in the DCRP, the depression program. And these include ketamine, which you heard all about this morning, vagal nerve stimulation, photobiomodulation, and devices for measuring physiological signs that may inform characteristics of depression and potentially its treatment. So these days I'm doing a little bit of everything. So thank you very much again for the invitation.
So thank you, David, and thank you, our other panelists. You know, one of the things we're most excited about with our panel today is sort of the diversity of areas of focus and expertise for all of our panelists. And we're looking for some good back and forth about how we address all of these different factors in treatment for depression across the lifespan and across different groups. So I'm going to start us off with an opening question, which is, what do you see as some of the most pressing issues facing the field of mental health in order to improve treatment outcomes for depression? And I'm gonna let somebody jump in if they'd like. Otherwise, I can direct it more specifically to panelists as we go.
Sure, I'll start. I think as someone who is primarily a psychopharmacologist in my particular neck of the woods, I think we need to develop antidepressant treatments that work better and faster than the current ones. There are many antidepressants on the market, but we know from studies and meta-analyses that about half of patients who try them won't respond to them. And of those who do, many will relapse. There's also the problem that antidepressants can take several weeks to work, which can be very frustrating for patients. And they may often stop taking them prematurely because of disappointment over the lack of, or apparent lack of efficacy. And plus, these antidepressants may have bothersome side effects, and these two can be a deal breaker for many patients. So I think certainly in psychopharmacology, we have a lot of work to do to come up with better and faster treatments.
I can add to that because in my research with very low income, racially diverse older adults, they about 50% are taking antidepressant medications, but they are still eligible for our studies. And it's just really not effective. And there are studies in geriatric psychiatry that these antidepressants are not as effective as in younger generations than in older generations, especially with low SES older adults. So I think that we have to really develop better antidepressants for older adults. And especially older adults, side effects are severe sometimes, and they stop taking it. And then they take it as needed. And that's not right. So I think that's really important. But for older adults, actually psychotherapy works sometimes better, or the combined psychotherapy and pharmacotherapy. But a lot of homebound older adults, or even just the regular older adults with low income, have limited access to clinic-based psychotherapy. So I think that's a real problem, and especially in my target population, homebound older adults. Across the country, there are very few programs that sends therapists out to older adults' homes. So I think that's really a problem. And with the COVID, we noticed even before that, but during COVID, the digital divide among low-income people, whether it's older adults or younger adults, they really can't access healthcare or mental health care. So I see the digital divide is an important factor for just access. Well, you have to access first to see the outcomes, right? So.
Absolutely, and I'll add in there and take a little bit of a pivot here, kind of in my lane and expertise as primarily engaging in kind of psychotherapeutic treatment, and that really kind of concerns something I started to highlight in my introduction, but that is really matters of kind of identification and access and utilization across diverse populations who are suffering with depression. And so Dr. Choi commented on some of the work that she does in some of those communities, and really thinking about some of the gaps we see, right? I'm drawn to some recent research that shows, that Black teenagers, for example, we are seeing kind of spikes in maintenance, particularly in the some of the periods kind of post the declaration by WHO of COVID-19 as a pandemic. We're seeing some increases in depression and anxiety, but we are not seeing those same uptick trends in utilization for our Black teenagers. That's concerning in and of itself. It's more concerning when it comes alongside research that's been released at the top of this year that are showing some alarming trends in the increase of suicidality among Black youth in those same age groups. And so that's just one example. But I think it speaks to the fact that, we heard some really great things in both of the talks this morning about advances and developments in different spaces and places. And some of the work that we do is saying, okay, that is great. And we also have to figure out ways for folks to take that up, to take it in, to feel like they can access it, to feel like it is for them, to feel like it's resonant for them. And so I personally, in the walk of the work that I do, see that as my side of the aisle of kind of bridging that gap a little bit between the great work that folks here are doing and getting it into the hands of certain groups who may be more susceptible and also may be more reluctant.
I think this is such an important conversation that the three of you are starting. I want to flip it a little bit and ask you next, what is most exciting to you in terms of what's happening right now, in terms of the field of the advances in the treatment of depression? So what are we doing right? Or what is a door opening that we need to follow all the way through, what would you identify as some of the more exciting advances in the treatment of depression?
Sure, I'll put on my psychopharmacologist hat again. I think I'm personally very excited about the rapid acting treatments. We heard Dr. Schatzberg's lecture this morning that covered ketamine, among others. And certainly one of the exciting things about ketamine is that it does seem to work faster than conventional agents. In my group, we're actually now getting a study underway of something called whole body hyperthermia, which is a device in which the patient lies down in and it heats their body a couple of degrees, like a mild fever. And preliminary data showed that one treatment of about an hour could resolve depression symptoms fairly rapidly. And the effects were sustained for about 6 weeks. So we're currently planning some follow-up studies in collaboration with Charles Raison, who did the original study. And not only are we going to verify, confirm the original findings, but also look into the mechanisms of action of this modality and how it might work in depression. The fact that something like whole body hyperthermia could work with just one treatment session and have a sustained effect over several weeks could be a game changer for many patients. It might circumvent the need for taking antidepressant medications on a daily basis, and it might prove more convenient than some of the other somatic therapies like ECT or TMS, which require 2-3 times a week dosing to be effective. So I think the idea that we might be able to treat depression faster than we could, and perhaps with non-pharmacological interventions, I think to me is very exciting, and it's a focus in our program.
So David, I'm going to ask you one follow-up question, which came up in the earlier discussion by Dr. Schatzberg, which is, with these faster acting antidepressants, some of them appeared to have not as sustained effects as this new treatment approach that you're talking about. So you identified sort of the slow ramp up to efficacy for established SSRIs or other medications as a barrier. But I'm wondering if acute quick action and rapid withdrawal for some of these newer medications could be, what are your thoughts on that? Could that be problematic from sort of a psychological dependency perspective?
Yeah, that's a very good point, Gabi. Certainly, many of the patients that I've seen in our ketamine clinic at MGH have struggled with that because the effects do tend to wear off quickly, and that creates frustration in the patient. And the goal with ketamine treatment is that it should not be sustained over long periods of time because we don't really know about the long-term safety of it. We know that it's not a drug to be administered lightly. And often there's a period of time where the patient will be weaned off. Instead of going twice a week, they may go down to once a week or once every other week. And many of the patients start to complain, well, after that first week, I start to feel depressed again. So there is an element of needing to sustain it that's important. I hope that we'll be able to develop other forms of ketamine that will have more sustained effects. Again, partly with that in mind, the whole body hyperthermia is appealing because that's something that supposedly, based on the first couple of trials in small samples, the effect lasted for several weeks. So that could be quite significant for patients.
Yeah, thank you, David. It's really interesting to hear about that sort of double-edged sword of both barrier and potential for dependency. And it sounds like some of these newer therapies that you're excited about might hit both rapid onset and sustained effects. So I'm going to turn back to our other panelists with our general question, which was, what are you excited about in terms of advances in depression right now? Or, you know, what are you optimistic about? If there's not something that reaches the level of excitement, what should we be paying attention to?
Yeah, in my experience for working with low-income older adults more than a decade now, that I see actually the community level stigma is really still there. It's a big factor, but it's decreasing, and especially older racial ethnic minority men who used to, in the beginning, like 2009, oh no, I don't have depression, but they tend to accept more these days. So I think that's one thing that I'm very hopeful about, that they can talk about, their depressive symptoms, finally, to a social worker like me. And then the second one is actually telehealth. So COVID effects really is important in telehealth delivery. So again, as social workers, we don't prescribe medications. We try to, link as many people to the services, mental health services. And I think that telehealth delivery made many people, to be able to access mental health services. But of course, as I said earlier, digital divide is still a huge factor in low-income communities. So I think those two are, in the delivery point of view, are very exciting.
Yeah, those are great points. And I agree that one of the byproducts and the exciting things that's come out of COVID is the proliferation, insurance coverage for and access to telemedicine. There are still divides, like you said, in terms of access to technology that will promote telemedicine. And we have some additional battles to fight as a field to continue to get insurance coverage for those services. But it's blown open a door that really was not open to the same extent before the pandemic. So Dr. Jones, can I turn to you now for your thoughts?
Absolutely. So those of you all who saw me on my screen may have seen me like jump for joy when I heard the stigma piece. I know that was also, I think, one of the holdover questions from the first session this morning is, and I would echo that again, and particularly in communities of color and minoritized communities. There's an interesting thing going on right now when we think about media. And again, this is kind of putting on my prior hat where I dabbled in a bit of public health and health promotion and communication, but we're seeing the ways in which media, whether they're, traditional forms of media and then new media, social media, TikTok, things of the nature, the way in which the proliferation of these narratives and stories about depression and anxiety are really bringing into discourse and conversation that this is a thing that it is okay, as Dr. Troy was saying, to identify as navigating with. And I think that is something I'm really optimistic about in terms of stigma reduction. The challenge that I think we face, even though that's not what you asked me, Dr. Liveron, but I'm going to say the challenge I think we face in that sphere, however, is some of the miscommunication and misinformation about treatment modalities that are appropriate or more appropriate and less appropriate, right? And so I think that is some of the work that we have transdisciplinarily before us, is to help the broader public kind of navigate from a mental health literacy standpoint those treatment options that are a good fit for them, and those which maybe they heard about something on a TikTok, but maybe it isn't something that is steeped in the evidence base. And I think for us to not actually grapple with that is only doing ourselves a disservice, because folks are getting this information in a multitude of ways. So that's one place where I find optimism and also caution. I think another space is really in some of the work that, and again, hats off here to Dr. Leva Stein and some other colleagues, have really started to think about ways in which something else that's happening in the media that you may have heard a lot about is the notion of kind of the talk and having conversations about racial injustice. And those of y'all who follow ADAA, you may have seen a tweet, and I said some of the research that we did recently shows that Black parents, as they are worrying about their children potentially experiencing racism or discrimination, that is actually linked to parental endorsement of depressive symptoms. The other side of the tweet, which I didn't do, it's kind of saved my hand here, is that we actually know that parents feeling more competently about being able to talk to their kids about race actually can be a solve. It can actually provide some protective function, not only for the parents themselves, but also for the development of depressive symptoms, internalizing symptoms within their youth. And so when we think about interventions like One Talk at a Time, when we think about interventions like Embrace, which is by Dr. Rihanna Elise Anderson and stands for Engaging, Managing, and Bonding Through Race, these are both really awesome opportunities to use family level conversations and communication to really serve a dual purpose of reducing symptomatology, both for caregiver and for youth. And so I'm really excited to see kind of the next iterations of that research.
So thank you to all the panelists for their thoughts on what we should all be looking for and following and feeling optimistic about. I want to build off of some of the comments that came out of that discussion and ask a question about what the panelists believe are some unique challenges facing individuals within BIPOC and LGBTQ plus communities, and how do you think these challenges affect depression treatment with clients with these identities?
A lot of my clinical work has been with Hispanic populations. I'm of Argentine descent, so I grew up speaking Spanish at home. And when I came to Mass General in the mid-90s as a resident, I was one of the few Spanish-speaking psychiatrists in the hospital. That's changed since then. So I became a go-to person for anyone who needed a Spanish-speaking psychiatrist. So I guess both of the main obstacles have been mentioned both by Dr. Choi and by Dr. Jones. There's the issues of access to care and the issue of stigmatization, particularly certainly among Hispanic men. There is a very strong cultural tradition to be the strong provider and defender of the family. And consequently, admitting to having depression, or for that matter, anxiety or any other psychiatric condition, may be viewed as a personal weakness. Not surprisingly, most of the Hispanic patients I've worked with are women, but I've had also several men. And I think our field needs to do more in order to eliminate those stigmas, because they are still very, very common.
Thank you, David.
Dr. Jones, you want to go first?
Yeah, sure. I'm happy to do that. And so I think, what I'll add to this conversation, maybe that's something different than what I've said so far, is again, when we think about going back to the summer of last year, and we think about June 2020, that kind of sticks out for a lot of folks because it brought sharp relief when we think about the case of George Floyd and Breonna Taylor. We also were seeing a very alarming uptick in anti-AAPI sentiment. So when we think about all communities, let me be clear, all communities live at intersections. When we think about those who, because of stigmatization and marginalization, are constantly wrestling with those intersections, we often can think about the BIPOC communities that you mentioned, as well as our LGBTQIA plus communities. And so I think there's this kind of idea, whether we're talking about a minority stress model, we talk about kind of this like double, folks have talked about double pandemic, folks have talked about these double endemics, depending on how you want to frame that, right? Of navigating these things that affect everyone, and then ways in which navigating certain stressors are heightened because of marginalization or minoritization. And so, I think that really thinking about, again, I'm going to speak from the psychotherapy framework. One of the things that I love to do as part of my training is I'm one of the supervisors in our program. And so new trainees are coming and they're saying, well, how do I take this, evidence-based treatment for depression and layer in thinking about, transphobia or anti-Blackness? How do I tease apart when a cognitive distortion is a cognitive distortion and when a cognitive distortion might actually be that was a microaggression, and how do I wrestle with that? So I think, one of the kind of, again, this may be something, as you hear it in my tone, that I'm also excited about is seeing how we as the field kind of continue to think about our evidence-based depression treatments, particularly from a psychotherapeutic base, and think about how we are intentional about considering those who are living visibly daily in those intersections, and how we not overhaul, but how we integrate elements of cultural relevance and salience into those evidence-based treatments in ways that are life-giving and edifying.
Yeah, that's great. I knew you were going to hit the points, so that's why I asked you to go first. So in my work with the regional and ethnic minority groups, I see still a lack of trust in the general healthcare and mental health care systems. And that's a huge factor, as we saw, COVID vaccine, acceptance rates, etc. So I think the one of the factors contributing, or or maybe may alleviate that lack of trust gap is to have more clinicians from that community. As Dr. Michelin said, he's the go-to kind of a doctor, right? So if we train more, clinicians from that minorities, they will, trust more. I have a bilingual Spanish English provider on my team, and I could see the Spanish-speaking older adults just love to talk to her. And they call her Angel, for example. And it's just really important how we train the next generation clinicians.
Yeah, thank all of you for those thoughts. And I agree, as someone who's actively involved in the training of clinical psychologists, we have a lot to do to diversify our field and to make sure that mental health professionals are representative of the people in this country. One other thought I had is people who identify with different racial and ethnic and gender sexual minority identities face instances of bias and microaggression within our existing healthcare and mental health care system. So in addition to, these longer term processes that we're working on, one action item I think I could highlight for everyone, which is something we can all do right now, is to assess our physical spaces or our Zoom backgrounds, assess our intake forms or our treatment outcome measures to make sure that we are creating a safe space for all types of patients. That includes, just as a simple example, not using gender binary classifications on intake forms, having signs that denote safe spaces. And that's a very applied thing that we can do now to help not participate in some of these instances of bias that occur in some of these institutional settings. For patients who have the trust to then engage in the system, the last thing we want them to do is bump up against these types of experiences.
Can I just add something there really quickly?
Yeah,
I'm so sorry.
Please do.
It made me think that is such a great point. It made me think about some ongoing work that we also have right now, which is, also, kind of sorry to say this, but you have to think about how some that there might be spillover and institutional mistrust And so we also have to recognize that in an age and in an era when there is some increasing mistrust of certain institutions, right? How that may actually manifest into folks beginning to be wary of interfacing with mental health and mental health, healthcare. And so I think it behooves us to be mindful of that and the way in which we engage our clients and our patients. So thank you so much for that.
Yeah, thank you. I'm going to shift gears a little bit, but as you can see, all of these questions really are interconnected in some of the themes that they're pulling for. I want to ask the panelists now, what are your recommendations for how we can integrate or sequence our existing evidence-based treatments across both discipline, psychiatry, psychotherapy, and age cohorts, and settings, right? What are we doing with patients? What are we doing with families? What are we doing with ourselves as clinicians? And what sort of advocacy action do we need within our mental health care system or community-based organizations? So it's a broad question, but if you could make a recommendation about how to integrate across these realms, what would your suggestion be?
All right, I'll start. So obviously, I mean, the literature by and large supports the combination of antidepressants and psychotherapy as the best way to manage depression on an outpatient basis. Most of the psychotherapies that have been well studied are usually cognitive behavioral therapy and also more recently dialectical behavioral therapy. Unfortunately, CBT and DBT tend to remain unavailable in the community because most practitioners are based in academic centers. So consequently, a lot of people who could benefit from these therapies don't have easy access to them if they can't get to academic centers easily, although they may be able to access pharmacological care. So I think one goal for the profession is to make these psychotherapies more accessible. What I'm excited about is telepsychiatry, because if we've learned one thing during COVID is that we can provide psychiatric and psychological care quite well remotely using Zoom and the other technologies. So this means that an individual who doesn't have easy access to an academic center could have access to a CBT or DBT therapist. So I think we're in a position to make a major change because we could now provide pretty much everything that the literature supports in terms of regular management of depression through the combination of medications and remote care. So I think there's a lot to be optimistic about in that regard.
Yeah, so I'm going to go first. Next, that is that in my work with low-income communities or the adults and middle-income, middle-aged adults, I think that their mental health needs cannot be separated from the other life stressors. So financial, distress. We did the outcome analysis about people who had housing issues. Of course, their Hamilton ratings scale score didn't go down much because that's always in their mind, right? So that's why I have always advocated, and my research is embedded in Meals on Wheels, Central Texas, where we can talk to my therapist are talking to the case managers next to, and this person has the housing issues, this person has, the healthcare access issues. Then they talk and they divide up which one belongs to problem solving therapy or behavior activation, which needs belong to case management and referrals to doctors, etc. And I think that's the way to also reduce the stigma, because it's like a one-stop shopping or a single point of entry. So I think that's really important because we should really recognize psychotherapy alone is not going to alleviate, depressive symptoms or anxiety of a lot of people who are going through daily life with such, kind of competing demands, big ones. Stressors are just all over. And I've served with, many older adults who, they're homebound, disabled, but they have to take 8-hour bus drive to go visit, their grandkids in jail, for example. And I don't expect their depression really, after like 5-6 sessions of short-term psychotherapy, gonna go. So in that case, we have to really provide material support, social support, and other, daily living support for all the adults, as well as the, middle-aged and younger people. I just don't know much about younger people because I'm a gerontologist. So I think that Dr. Jones can talk more about that.
Yeah, no, absolutely. That fits in so well. I was, down here, I had kind of really thinking about that kind of continuity of care from the start. I think it's so, really awesome. When I said my intro remarks, I wasn't just kind of giving the standard academic like niceties, but to have representation in psychology, social work, psychiatry. We might be onto something if we think about how this panel is intentionally constructed and thinking about how we think about the sequencing and integration as the question asks, right? Having that holistic approach is important. I have been in awe of many of my colleagues here at VCU in the way in which they are really utilizing their integrated primary healthcare settings as a place for a lot of really awesome kind of interventions for youth and for adults with regard to kind of depression and depressive symptoms and so forth. And so I think that is very key. I just want to double down on that. I think the other piece that is striking for me is also thinking about the family. So again, child and family. So I've been thinking a lot more about the family system, and depending on your theoretical orientation around thinking about family systems, we think about how some of the ways in which the identified client, who is that, and how do we think about that? And so I think one integration is thinking about ways in which, okay, here's a child who is coming in, and maybe we're going to be doing some TADS or coping CAD or something, right? But also really checking in about what's going on for the caregiver kind of structure within that family, and are there ways in which and I know that this can be limited by how we bill for insurance, so please hear my heart there, and obviously there are hurdles for us to navigate, and thinking about also how we can kind of touch within family systems, and thinking about some of the connections that we're seeing in the kind of depiction and expression of depression among multiple members in the family, and how we can use interventions that treat a thoroughfare, a through line across the family and across development is something else that I think is really worth our time.
So like Sean, I'm also really enjoying being a part of this panel and hearing the diversity of perspectives, both in terms of discipline and areas of focus. One other thought that I had about this question of integration or sequencing is one thing I don't know we do very well in mental health is to consider consumer preference. So we tend to approach these questions from a top-down perspective from the research base, where we test, psychotherapy versus medication versus the two treatments together. And I think we have some work to do as a field to really ask the questions about whether clients prefer psychotherapy or medication, and then go a step beyond that and ask, how did they define successful treatment? So in most of our westernized medical models, we define successful treatment as symptom reduction. But for some of our patients, they may not be thinking about it that way. They may be thinking about it from a behavioral perspective. So are they able to live a valued and meaningful life irrespective of symptom fluctuations or upticks in distress? Are they particularly concerned about side effects? So even if there is symptom reduction, there's one or several sets of side effects that would be determinative, and that would make them feel like treatment was a failure or not what they're looking for. So I would just push against that paradigm that we can all fall into of assuming we know what clients are looking for in terms of successful treatment outcome. And I think we need some more science behind that to ask questions, and also maybe challenge some of the ways we operationalize treatment success in our evidence base for psychotherapy. So I just wanted to add that additional thought. I'm mindful of the fact that we actually have a number of audience questions, so I'm going to invite Barbara to rejoin us to moderate some of those questions.
To reappear, here she is. Thank you all. I want to in particular thank Dr. Jones for commenting on the very intentional nature in which this panel and also this whole event was structured. I'll put a plug in later for ADAA, but I do want to mention in that context that certainly one of the reasons that I've been so active in ADAA has been the extent to which it is so active and intentional in being inclusive on so many levels. So certainly from an interdisciplinary perspective, it is substantially more inclusive than some of the other organizations I intersect with. From a certainly communities of color and LGBTQ plus communities, but also in terms of geography. There is a larger international component to ADAA, international members and international attendees and participants than many of the other organizations with which I'm active. So I think I appreciate you noticing that, Dr. Jones, excuse me, that's not an accident, and more on that another time. I also want to invite, while I'm screening some questions, and I meant to ask Dr. Stein as well about this, if you would toss your social media handles in the chat for audience members. I've been stalking all of you on social media just to see where I can follow you. I'm stunned. Dr. Jones, I couldn't find social media. I couldn't find, Twitter for you, but I think one of the really nice ways, we've talked about, like, how do we increase access? How do we increase access, not just to sort of those of us who sort of know, who to follow or what to, what organizations to check in with, but to really disseminate directly into the general public what's going on in this case, depression across the lifespan, treatment of all kinds, assessment, intervention, access, particularly for marginalized communities who don't have great access. And I want to put a plug in for Twitter, weirdly, on that front. But any sort of social media, whether it's your own, ideally, but also others. If there are other folks on social media you think we should all be following, specifically around depression across the lifespan, but really, here's a moment for whatever reason you want to promote someone else's social media, please go ahead and toss that in the chat. So in no particular order, Robin Fine asks, as a private practice clinician, I feel like I spend too much time helping my clients unpack social media. Sorry, Robin, I'm not helping that. To unpack social media and news media messages in a more rational way. Has depression become now more than ever a result of the polarization in our society? And I think, Dr. Jones, I don't mean to keep picking on you, but you mentioned June of 2020, obviously, as a crucial point in our ongoing history. Just toss that to I'd like to toss that to the whole panel. And I'll remind folks to unmute themselves.
So I'll give it a go. So first of all, Robin, thank you for the question. Yeah, I think it might be unfair for me to say to that now more than ever a result of the polarization of our society. That said, I think as for those of us in the audience who are clinicians, who are watching this, who are clinicians, I think we have to be right. We always have to be mindful, in my view, anyway, in my orientation. We have to be mindful to the fact that context matters, and so whether it's now more than ever is maybe not for me to say. But what I will say is we should be mindful that when clients, when individuals, adults, children, teens, families couples are walking through the door, that this is a context that the current kind of socio-political climate is a potential contextual factor that we should maybe ask about, assess its salience and relevance in the lived experience of our clients. I can understand feeling, and again, as someone who's supervising, student clinicians in training who are feeling more novice. I get this question a lot, like, there's everything is about like this, or particularly those of us who are seeing or working with Gen Z folks, and they're like, I feel like I spent half of a session like, disproving like a TikTok video about what something is and is not. And, that is different than when I was training. And I think it's nonetheless salient, and we have the tools, right? I think that we have the tools in our repertoire of what we know are the evidence-based kind of practices and skills, and ways to engage that. I think to me, the biggest thing is an awareness that we are currently in a climate that I think folks are going to do some research. Folks are doing research about it now, but they're going to also reach back and do some research about this era and what it meant for psychotherapy writ large, and perhaps about psychotherapy with regard to depression per se. And I think we'll learn now. I think we only can see in part, as they may say, but I think the awareness now of what we are in is worthwhile for us as clinicians.
I'm going to actually be very anti-discussive and sort of cut us off there on that question, so that we can take maybe 90 seconds on a immense question. So I'm sure you'll all cover it in 90 seconds, no problem. The beginning of the question has already been answered. The panel has really beautifully already talked about the role of politics and politicians and systems structuring that promote discrimination and depression. So sort of within the context of the ways in which allocation of resources and health and jobs and housing and education affects discrimination and depression, if you were to make a recommendation on what we can do to reduce it, clearly you can solve this in 90 seconds. This should be no problem for any of you. A thought, maybe a brief thought on what we can start to do to reduce those effects.
So I'll jump in and try not to take all 90 seconds. I think the first thing we have to do is acknowledge those effects as mental health professionals and know what our own limitations may be. I think we have roles to play on multiple levels, both as an advocate for societal level change, and then also within our practices to figure out how we can act to make some of those changes. To pick up on what Dr. Choi said, the days of ivory tower, evidence-based, empirically supported psychotherapy treatments that just focus on cognitive distortions and the context of a 50-minute hour may not be relevant if we are not focusing on the larger social and contextual factors that our clients are embedded in. And if we are not hooked into case management systems, we have to do our due diligence to look at some of those barriers. And, those are things that aren't tested in clinical trials of psychotherapies at this point in time, but yet so critically important. So I'm gonna leave time for others.
All right, I'm gonna take the silence and jump into it. Just with our last couple of minutes, wanting to be respectful of everybody's time. It is cliche, of course, and I really do want to indicate this is not at all sort of a trite throwaway remark. How grateful we are for everybody's time today, in terms of our presenters, obviously our panelists, obviously our key speakers, the diversity of perspectives and opinions, the discourse, the zooming in and out from the very, very small details of what's going on in depression assessment and treatment to the 30,000-foot view of issues of our field and what we need to be doing next. In so many different domains. We're deeply, deeply grateful for your time, your expertise, your passion in these fields, your training, your research, your clinical care. Tremendously grateful. I also want to thank, I'm realizing I'm supposed to be sharing my screen now. So I'm going to say goodbye to our panel so that I can share our screen. I'll give folks one more second to jot down social media handles if they haven't already. I do want to thank ADAA, of course, for hosting. Here is just again a reminder: Dr. Schatzberg, Dr. Stein, Drs. Choi, Jones, Liverant, and Michelin. And I want to invite everybody to the Anxiety and Depression Conference. We are planning to have that in Denver this year with the theme of common psychopathology. What can the past tell us about the future? As I alluded to earlier in our discussion, ADA's conference brings together clinicians and researchers really from around the world, from multiple different disciplines and multiple different perspectives to focus on anxiety, depression, and co-occurring disorders. It's a tremendous conference and a tremendous opportunity. I will also mention a plug for the organization more broadly. ADAA is very much not just the conference. If you're not already a member of ADAA, please do consider joining. You're going to have access to a huge range of things, from webinars to special interest groups, peer consultations, find a therapist, ongoing research, the free online access journal, Depression and Anxiety, of course, networking and collaborating and being able to connect with like-minded and also folks with different perspectives, which is terrific. So thank you all. If you have questions, you can certainly reach out to us. I really wish right now that I had that address.
Webinars@adaa.org.
Thank you, Sasha, for always saving me. Webinars@adaa.org. And you can see tremendous free resources, many of which are also available in Spanish at adaa.org. So thank you all to ADAA, to our audience members for joining us on yet another Zoom after 18 months of Zoom, and of course to our presenters. Have a great day.